sessions of Sri Lanka College of Oncologists. We warmly welcome all the local and international participants who are joining us here in person as well as online. Before we move on to today's proceedings, please rise for the national anthem. Thank you, ladies and gentlemen. Without much ado, let's move on to the first item in our agenda for today. Symposium on Head and Neck Cancers. Our first speaker for today is Professor Prathamesh Pai. Professor Pai is a professor in the Department of Head and Neck Surgical Oncology and is the convener of Head and Neck Disease Management Group at Tata Memorial Centre, Mumbai, India. He's a versatile head and neck surgeon with special interest in oral and transoral laryngeal laser surgery, as well as skull-based surgery with focus on minimal access. With over 90 peer-reviewed publications, he's the co-editor of a monograph on surgery of larynx and hypopharynx and has authored chapter on management of paranasal sinus tumors in UICC Manual of Clinical Oncology. He'll be talking on surgical principles of oral cavity cancers today. Prof. Pai, over to you.
Good morning, everybody. Thank you for the invitation to speak on the surgical management of oral cancers. When we come to oral cancers, you have triaged into early and advanced cancers. In the early cancers, the lip and buccal mucosa, we find that surgery is a preferred treatment. What are the issues in early oral cancer? Margins, function preservation, management of the N0 neck, and risk stratification for adjuvant therapy. When we come to margins, this is a very tricky situation, especially when you want to avoid adjuvant therapy or re-resection. The issues in achieving an adequate margin are tissue shrinkage, the margin adequacy, and revision of the specimen or the tumor bed. Now, when we looked at the patients who were of early oral cancers in tongue and buccal mucosa, the patients who had tongue cancers had a 23% possibility of shrinkage as compared to the buccal mucosa cancers. And the T1, T2 had more than 25% possibility of shrinkage as compared to the T3 and T4. So this we need to plan when we plan the margin so that you can assume a 25% shrinkage and then plan for the adequate margins to be taken intraoperatively. Now, having taken the margins, where should you actually direct your margins from? There have been some who take it from the patient side, and there are some who take it from the tumor specimen. And what is known and proven now is that the margin from the outlock specimen remains the only prognostic relevant margin. Various studies have shown that the final pathologic analysis from a specimen-derived margin achieves a negative margin in more than 84% of patients. And when you re-resect this margin based on your specimen-derived margin, you can avoid adjuvant therapy in more than 40% of your patients. When we looked at the cut margins, we realized that in the patients who had cut margin positivity, the patients were more likely to have a local recurrence. Microscopic cut-through negatively impacts upon disease control, and frozen section, though height, is unable to control the margin. Patients with initial negative margins had low control rates, lower recurrence rates, and longer interval to recurrence than those with closed or positive margins. This study looked at millimeter to millimeter increase in margin and what was its impact on the survival. And they found that each millimeter increase reduced the risk of death at 5 years by 8%. What about revision of margins? We often feel that we can revise a margin. Various studies and this meta-analysis have shown that a margin revision does not improve local control. If I have an R1 and I compare it to a revised R0, if I have an R1 and I've revised it and I've achieved an R0, you have a 1.5 to 2.5 hazard ratio. That means you have 1.5 times more chances of failure if you do a margin revision. It does not improve local control. Early oral cancers is all about function preservation. So we resect these tongue cancers, the buccal mucosa cancers, and we often have impediment in swallowing in mouth opening. We did this study of a functional outcome following surgical treatment of an early oral or early tongue cancer. So we randomized patients to primary closure and secondary healing. We looked at the operative time, the blood loss, pain, the bleeding, speech quality, swallowing restoration, and tongue mobility. The ones that healed secondarily had lesser errors of speech, better swallowing, and significantly better tongue mobility. Functional outcomes after surgery for early tongue cancer are better with anatomical preservation of structures and less physiological disruption of speech and swallowing. What about the management of neck? There has been a lot of debate over the past 5 decades whether you should do an elective neck dissection or wait and watch. Both the groups have very strong arguments for doing either. These arguments were led to rest with this large randomized control trial from the Tata Memorial Hospital led by Dr. Cruz. 496 patients of T1, T2 oral cancers were randomized to the elective neck dissection versus the therapeutic neck dissection. When you look at the disease-free survival, for every 4 neck dissections, you will prevent 1 recurrence. When you look at the overall survival, for every 8 neck dissections, you will save 1 life. So it was a conundrum resolved. Oral cancer is a high-risk site. Ultrasound and CT are better than clinical examination. Occult metastasis occurs in almost 1/4 of your patients. And if you have a nodal manifestation, it is a harbinger of a higher intensity neck dissection, higher chance of extracapsular spread, higher chance of intensified adjuvant therapy, and a poorer survival. So elective neck dissection should be done for all early oral cancers. What about risk stratification now? In early oral cancer, this seems to be a problem. We finally get a histopathology report. We get with the depth of invasion seems to be higher. The worst pattern of invasion is now commented on, and you have got a perineal invasion and lymphovascular emboli. Should you treat this with adjuvant radiation therapy? Now, Brandwein and Gensler looked at the pattern of invasion and showed that the ones that had this pattern, type 5 pattern, where the tumor cells were more than 1 millimeter away from the main tumor, seem to have a poorer survival. We looked at our own data of perineal invasion with more than 1,500 patients. The perineal invasion was seen in almost 20% and more so in the tongue cancers. Perineal invasion significantly affects disease-free survival and overall survival. And adjuvant radiation improves survival. So way back in 2013, Brandwein and Gensler looked at risk stratification of these patients based on worst pattern of invasion, local host response, and perineal invasion. It is incumbent on us to use this risk stratification in order to plan adjuvant therapy in a tumor board. This international collaborative study looked at more than 1,200 patients, and they found that the ones that had closed margins had a 2-fold risk increase in risk of recurrence. So an adjuvant therapy is mandated. Coming to the advanced cancers. In advanced cancers of the lip and oral cavity, surgery followed by radiation or chemoradiation is the standard of care today. What is the magnitude of problem? The 5-year survival, in spite of all this treatment, is 30 to 40%. And survival is determined by the surgical clearance with good margins, the neck nodes, and adjuvant therapy. So clearly, an advanced oral cancer is the one which has more than 10 millimeter of depth of invasion and has spread into adjacent structures, the bone, skin, with a depth more than 2 centimeters. Even amongst the neck nodes, patients presenting to you with more than 3 centimeter node is an advanced cancer. Now, when you come to advanced oral cancers, these are the 3 issues: triaging or selecting out the curative case, planning the adequacy of resection, and delivering timely adjuvant therapy. When you look at buccal mucosa cancers and tongue cancers, we find that they have a late presentation, there's an early involvement of mastocytic space, and a late but advanced nodal spread amongst the buccal cancers. Amongst the tongue cancers, they present early, but they present in advanced stages. There's an inferior and a posterior spread coming onto the hyoid, the vallecula, and often you have multiple bilateral neck nodes. Involvement of the infratemporal fossa is a bugbear of all surgeons because it concerns local control, perineal invasion, and a microscopic residual disease. Chuntao Liao from Taiwan looked at the T4B cancers and he found that the supranotch cancers had a poorer survival. they had a higher locoregional recurrence because of more involvement of the pterygopalatine structures. Closer to the skull base, you were not able to get an adequate surgical margin. And then combined with lymph node metastasis and perineural spread, it was a recipe for disaster. The infranotch tumors, however, had a better 5-year local control, and they were better prognosis if they had no neck nodes and no nerve invasion. So when we looked at the T4A and the T4B cancers, we realized that the factors influencing the disease-free survival was margin positivity, masticator space involvement, nodal involvement, and perineural invasion. If you see the adequacy of margins, the possibility that you will fail in margins was higher when you had a T4B cancer. And when you looked at the disease-free and overall survival in the T4A and T4B, the nodes and the margins seem to make a huge difference in the survival rates. Neck nodes, as we all know, are a poor prognostic indicator. The moment you have an N3 node, your chances of failing increase by more than 50%. And the overall survival drops down to 0 at 2 years. So we need to look at the patients whom we are selecting for surgery. The ones that have a nodal metastasis in the T4A and T4B cancers all do poorly. The ones with T4A without nodes do exceedingly better. So you need to triage out a curative case because you need to ensure adequate margins. So select a case where there is no gross perineural spread, no involvement of the high infratemporal fossa, and there is less than 180-degree contact with the common or the internal carotid artery. Again, low volume neck metastasis and soft tissue rather than bone involvement indicate a lower possibility of distant metastasis. So in advanced cancers, the second issue is of adequacy of resection. So generally, we select a patient whom we can get a complete R0 clearance. The minimum margin should be more than 5 millimeters, and a 3-dimensional resection is to be achieved. Margins are a poor prognostic factor, as we have seen, and less of the margins is an unfavorable factor for local control. So you have the possibility that you may have an unresectable disease. So the criteria are an adequate surgical clearance is not achievable, extensive ITF involvement and base skull involvement, extensive soft tissue disease, skin edema, and ulceration. The nodes which are clinically fixed and infiltrate the internal carotid artery or extensive infiltration of prevertebral muscles are unresectable. Now, between the resectable and the unresectable, there are a group of patients who are borderline resectable. Now, when you look at the patients who have lesions with diffuse margins, such as this cancer, a buccal cancer coming out over the skin, with peritumoral edema up to or reaching the zygoma, supranotch involvement of the high ITF, in tongue cancers, tumors extending to or below the level of the hyoid bone, extending onto the vallecula, and extensive skin infiltration. These are possibly borderline resectable. You may not get an adequate margin, but you may want to operate these upfront. Even amongst the nodes, if you have a mobility in at least one plane, but there seems to be gross nodal extension, those are the ones that require to be considered for some kind of treatment in order to bring them into the realm of resectability. What then is the role of induction chemotherapy? This large data that we analyzed, more than 700 patients, the reason for giving chemotherapy was peritumoral edema, extension of tumor into the vallecula, and extensive skin infiltration. With 2 cycles of chemotherapy, we found 40% could be resected. And the ones that were resected had a better control than the ones and survival than the ones that couldn't be operated. Now, when we looked at the nodal factors. When we gave chemotherapy for nodal disease, the favorable response of chemo was seen in almost 64% of patients, and up to 87% of the nodal responders were amenable to curative intent treatment. Finally, having operated them, we need to deliver adjuvant therapy on time. Now, survival rates improve with adjuvant therapy, but still locoregional and distant metastasis is seen. Now, when we looked at the treatment intensification in 2004, the two studies of VORTC and RTOG did a combined analysis, and they found that the margin positivity and extracapsular extension were the ones that seemed to benefit from intensification, with a 9 to 11% disease-free survival benefit and up to 13% overall survival advantage. Now, timely adjuvant therapy is reflected by our surgical morbidity, the complex defects that we create, compromised nutritional status of the patient, and flap failures. Why we need to dwell on this? Because an average loss of locoregional control is to the extent of 12 to 14%, as seen in this study of review of literature of more than 62 studies. And even if we want to give chemoradiation, if the delay is more than 10 days, all this advantage of chemoradiation is lost. So when we look at early oral cancers, achieve adequate margins, do function preservation surgery, do a neck dissection for all your oral cancers, and do a proper risk stratification in order to plan for an adjuvant therapy. In advanced oral cancers, triage out a curative case, achieve an adequate resection, and do timely and effective adjuvant therapy. Thank you very much for the patient listening.
Thank you, Professor Prasamesh, for that comprehensive lecture. And for the participants, we'll have all your questions at the end of the symposium. And it's my pleasure to invite the next speaker for the day, Professor Ashwini Badrukar. Dr. Badrukar is a professor of radiation oncology at Tata Memorial Hospital, Mumbai, which is one of the premier cancer centers in Southeast Asia. She specialized in radiation treatment of head and neck and breast cancers. She is well known for her expertise in brachytherapy in head and neck as well as breast cancers. Dr. Badrukar is actively involved in clinical research and is the principal investigator of various trials in a subject. She has delivered more than 150 lectures in national and international congresses and has more than 100 publications in her credit. Dr. Badrukar is a member of many professional organizations, including GECEXTRO Head and Neck Working Group. She is a fellow of UICC and also Indian College of Radiation Oncology. She was awarded Satyapal Agrawal Gold Medal for her post-graduation in radiation oncology by Diplomat of National Board. She is also a recipient of International Development and Education Award by American Society of Clinical Oncology. Over to you, Dr. Badrukar.
Good morning, everyone. First of all, I would like to thank Sri Lanka College of Oncologists and especially Dr. Krishanti for this kind invitation to speak in the annual academic sessions this year. Next few minutes, I'll be speaking about adjuvant treatment of oral cavity cancers. Management of oral cancers has evolved over a period of few decades. From single modality treatment of surgery or radiotherapy, it has now moved to multimodality approach. There have been advances in understanding the biology of the disease, and also there have been exciting advances in planning and implementation of radiotherapy. In addition, there have been effective chemotherapeutic drugs, which all has led to possibility of intensification of treatment and thereby improving survival of these patients. Surgery still remains the mainstay of the treatment. However, as a single modality treatment, especially in advanced tumor, it is quite ineffective. The need for adjuvant therapy was evaluated way back in 70s and 80s, and there have been various comparative studies which have looked at surgery alone versus surgery post-op RT, especially in stage 3, stage 4 tumor. And what they observed was that with addition of radiotherapy, there was almost 20 to 30% improvement in the loco-regional control rate, while at the same time, there was improvement also in the overall survival to the extent of 10 to 20%. This is one of the randomized trials which was conducted in eastern parts of India. It randomized patients with buccal mucosa cancers to surgery alone versus surgery plus postoperative radiotherapy. What they observed was that with addition of postoperative radiotherapy, there was almost 30% improvement in the disease-free survival. However, this did not translate into overall survival benefit. There is another large study which evaluated the SEER database between 1988 to 2000. They studied around 8,700 odd patients, of which more than 2,000 patients had oral cavity cancers. They observed that when surgery was given alone, then the overall survival was around 33.4%, while with addition of radiotherapy, there was almost 10% improvement in overall survival. These studies kind of established the role of postoperative radiotherapy in patients with oral cavity cancers. We at our center also looked at patients who were treated over a period of decade, and we studied more than 1,000 patients. And we observed that when patients were treated with surgery and postoperative radiotherapy, there was definite improvement in the local control, loco-regional control, and disease-free survival when compared to that of radiotherapy. We also evaluated various prognostic factors and found that nodal status, extranodal extension, cut margin, site of the primary, and dose of the radiotherapy were important factors which had impact on the disease-free survival. So which are the factors which should be considered while giving radiotherapy? This can broadly be classified as major factors or intermediate or other adverse factors. Major factors are the ones which are typically seen in advanced stage disease, and these are stage 3, stage 4 tumors, positive margin, nodal metastasis, and extracapsular spread. However, there are few other factors which are becoming more important in early stage cancers where there is need for adjuvant treatment. And these are perineural invasion, depth of invasion, lymphovascular emboli, worst pattern of invasion, tumor differentiation, and tumor budding. In addition, we also need to take into account the spillage of the tumor during surgery as well as multicentricity. Perineural invasion is one factor which is becoming important, especially while considering adjuvant treatment for early stage tumors. At our center, a study was done to evaluate the importance of perineural invasion in 1,500 patients from a prospectively maintained database. The incidence of perineural invasion in our series was 20%, and it was more in tongue cancer. PNI was an independent factor for disease-free survival as well as for overall survival. In patients who were node negative, they had better outcome in presence of a PNI if adjuvant radiotherapy was given as compared to in patients when adjuvant therapy was not given. While our study showed that PNI was an independent prognostic factor, there are various other series which have shown that PNI may not be an independent prognostic factor. So currently what we know about presence of PNI is that it is associated with higher T stage and higher regional recurrence. And in absence of all other adverse factor, we need to take into account the size of the nerve involved, whether it is small nerve or large nerve, whether the invasion is intratumoral, peripheral, or extratumoral, and number of foci while making decision for radiotherapy for these particular cancers. Depth of invasion is another prognostic factor which has become important and now has been incorporated into the 8th HSCC system. This is an international collaborative study of which our hospital was a part, and they studied around 1,400 patients over a period of 2 decades. And they studied the impact of depth of invasion and radiotherapy in presence or absence of adverse pathological factor. These are the graphs which show the effect of radiotherapy when no adverse pathological factors are there. These are the patients who have not been radiated, and these are the patients which have been radiated. And there is no statistically significant difference with addition of radiotherapy when there are no adverse pathological features. However, when there are adverse pathological features in patients who have depth more than 10 millimeter, there is statistically significant improvement in the disease-specific survival with addition of radiotherapy. So they concluded that depth of invasion is not an independent prognostic factor. However, in presence of other adverse pathological factor, it should be considered while decision making for radiation therapy. Currently, as per the 8th AJCC staging, we are considering radiation therapy whenever there is depth of invasion of more than 10 millimeter. This particular study from Gensler et al., it looked at a novel histological risk assessment system, and this was based on various poor prognostic factors, which such as perineural invasion, worse pattern of invasion, and lymphocyte infiltrate. The scoring was done for each prognostic factor from 0 to 3, and based on that, a risk score was developed. The risk score of 0 was considered as low, and these were supposed to be of good prognosis, and therefore the radiotherapy was not recommended in this patient. Similarly, intermediate risk patients, there were not recommended radiation therapy. However, when the score of more than 3 to 9, there was a need of addition of radiotherapy, even though the margins were more than 5 millimeter. Another contentious area is role of radiotherapy in N1 tumor, and this especially so in early stage disease. This study by Chen et al. Looked at the National Cancer Database from 2004 to 2013, and they looked at patients who were T1, T2 tumors and with single node metastasis. Patients with other adverse pathological features were excluded. There were 1,500 patients with oral cavity cancer and around 800 patients with oropharyngeal cancer. And they observed that addition of post-operative radiotherapy resulted in statistically significant improvement in the overall survival. So the overall survival without post-op RT was 53%, and it improved to 60% with addition of post-operative radiotherapy. The benefit was observed more in patients who were less than 70 years of age and who had T2 tumors. And therefore, they recommended post-operative radiotherapy in patients who had. Once the decision is made for post-operative radiation, we need to plan and implement that. Currently, intensity modulated radiotherapy is the standard of care. Therefore, target volume delineation is extremely important. However, it is very, very challenging. We need to take into account the preoperative imaging, endoscopic finding, intraoperative detail, and finally histopathology report. All this information needs to be transferred on the postoperative contrast enhanced CT scan. While it is recommended to co-register the images of the preoperative and postoperative scan, it always is very challenging and inaccurate. Therefore, delineation needs to be done as per the anatomical boundaries. While we give very small margins such as 5 millimeter in radical cases, in postoperative cases, we need to give larger margins of 1 to 1.5 centimeter so as to take into account uncertainties. Similarly, for nodal disease, we need to give at least 10 millimeter margin so as to cover the perinodal extensions adequately. And CTB2 is the uninvolved nodal region, and this depends on the site of the primary and the nodal involvement. With plastic reconstruction becoming common for oral cavity cancer, contouring for oral cavity cancer has become more challenging. The junctional tissue of flap and normal tissue should be considered as high risk and should be covered. It will be really helpful if the surgeons report the extent of flap in more details, and if they could put the clips at the site of the flap attachments, it will help the radiation oncologist in target volume delineation. As a radiation oncologist, we need to take into account the atrophy, fibrosis, osteoradionecrosis that may happen in the osteocutaneous flap during our planning process. Dose of radiotherapy has been well established in 90s by this randomized trial by Professor Peters, and they have very clearly shown that for low risk patients, doses of 57.6 Gray are adequate, while for patients who are high risk, such as extranodal extension, doses of 63 Gray are recommended. Treatment package time is also important, and this is the time from surgery, date of surgery to completion of radiotherapy. Way back in 90s, Parsons et al. Showed that the treatment package of 100 days is important. More recently, Rosenthal et al. In the final report of the randomized trial by Professor Peters showed that the treatment package time of more than 85 days results in inferior outcome. Similarly, in the randomized trial by Kianang et al., they showed that when the treatment package time is less than 11 weeks, the outcomes were excellent, while when the treatment package time exceeded 11 weeks, the outcomes were not so satisfactory. Is there any role for adjuvant brachytherapy? Adjuvant brachytherapy has been considered at few centers, and this is especially useful for escalating the dose locally in situations such as margin positive disease. Typically, boost doses of 16 to 24 Gray are given, and the catheter placement is done intraoperatively at the time of surgery, and postoperatively, the radiation is delivered. This kind of technique has been shown to have excellent local control rates and overall survival. Even after radiotherapy, we do see local recurrences to the extent of 25 to 50%. In advanced disease, we see distant failures to the extent of 20 to 25%, and the 5-year survival ranges between 30 to 90%, depending on the stage of the disease and presence of pathological factors. There are certain pathological factors which result in poor outcomes, such as multiple nodal involvement, extranodal extension, and positive margin. And these are the situations where there may be possible need of treatment intensification. There are various ways in which we can do treatment intensification. It can be either done by use of concurrent chemoradiotherapy, use of altered fractionation, or concurrent radiotherapy and targeted therapy. In the interest of time, I will only cover concurrent chemo. These two trials established the role of chemotherapy in addition to radiation in patients receiving adjuvant treatment for head and neck cancers. While these two trials had similar design, their outcomes were slightly different with URTC trial showing improvement in the overall survival, while RTOJ trial did not show improvement in overall survival. Then they did a pooled analysis which looked at various factors, and they found that the significant factors for use of concurrent chemoradiation were extranodal extension and positive margin. There was a meta-analysis later which looked at all the trials which have evaluated the role of concurrent chemotherapy along with radiation in adjuvant treatment of head and neck cancers. And they found that there was significant improvement in overall survival with addition of chemotherapy. Chemoradiation was especially beneficial in patients who had high risk factors such as extranodal extension, positive margins. The benefit was seen more in younger patients less than 70 years of age, and this resulted in significant toxicity. There was a need for intensive supportive care with addition of chemotherapy. We at our center also have done a large randomized trial of 900 patients, and this trial was a 3-arm randomized trial where we compared surgery with surgery followed by conventional radiotherapy, surgery followed by concurrent chemoradiation, and surgery followed by accelerated radiotherapy. However, we could not find any difference in the locoregional control rate with intensification of treatment. Timing of chemotherapy has been a topic of debate for long. To address this issue, randomized trial was done at our institution. This trial compared once-weekly chemotherapy with 3-weekly chemotherapy. We observed that the locoregional control at 2 years was significantly better in patients who had undergone 3-weekly chemotherapy. However, the toxicities were much higher in patients who had undergone 3-weekly chemotherapy, And they concluded that 3 weekly chemotherapy should be considered as a standard of care. So finally, how should we manage oral cavity cancer? We need to adopt a risk-tailored approach. Whenever there are high-risk features such as margin positivity and ENE, post-op CTRT should be considered as a standard of care. And while we can achieve a good loco-regional control rate, still distant metastasis remains a challenge in this patient population. When there are intermediate risk prognostic factors such as T3, T4, lymphovascular invasion, perineural invasion, close margin, post-op radiotherapy alone should remain a standard of care. With that, we can expect a good loco-regional control of around 78%. And in situation where there are less low-risk tumors such as T1, T2, without any adverse prognostic factor, surgery alone should remain a standard of care, and a very high local control of around 90% can be expected in such situations. So to conclude, postoperative adjuvant radiotherapy improves locoregional control and overall survival in patients with oral cavity cancer. Postoperative radiotherapy alone should be considered in intermediate risk cases, while postoperative radiotherapy with concurrent chemo should be considered in presence of high risk features such as extranodal extension and margin positivity. Risk-tailored approach is necessary. We should define our volumes carefully, and this should take into account the risk of recurrence and presence of occult metastasis. A dose of at least 57.6 gray is required for low risk cases, and for high risk cases, 63 gray dose is recommended. Attention should be given in keeping the overall treatment time optimal. I would like to thank my colleague, Professor Sarvani Ghosh-Laskar and Dr. Tanvi Shahid for their inputs in my presentation. Thank you very much. I will be happy to take any questions.
Thank you very much for that very informative presentation, Professor Badruka. Both Professor Pai and Prof. Badruka are joining us virtually now. We are very humbled by your presence with us today to share your experience and knowledge with us. Before we move on to our third presenter, we can accommodate some questions from the audience to Prof. Pai and Prof. Badruka.
Hello, thank you, Prof. Pai and Prof. Badruka for the excellent presentation. So this question is to Prof. Pai. What's your management of flap recurrence in your institution?
For flap failure or tumors coming alongside the flaps, we need to evaluate, go back and see whether you achieved a good clearance. So we would look at the pathology reports, we would look at the initial imaging and try and understand why we failed. If there was a technical issue towards clearance, we would try to address that and see if it is possible. More importantly, we would now like to see whether we gave adjuvant therapy to this patient, whether this patient has an adequate disease-free interval, and what is the site of the primary. We have all read the Goodwin's study, which looked at all the sites of recurrence, the disease-free interval, and its impact on the clearance and survival. So if you have an oral cavity cancer and your disease-free interval is less than 6 months, the prognosis is extremely poor. So whenever you have a recurrence, and especially around the flap site, try to analyze what is the site of the primary, what is the disease-free interval, and what is the recurrence stage. If you have a T1, T2 recurrence staging, and you have the possibility of either adjuvant therapy or re-irradiation, then that patient should be considered for surgery. Thank you.
Thank you. Ashwini, you, Professor Pai, and you said margin revision is not useful. So at Tata Memorial, even if it is an R1 resection, do you all proceed with concurrent chemoradiation without revising the margin?
So when we looked at the margins and we try to analyze, is it possible to re-revise? So as we looked at literature, you realize that if your margin revision is in the soft tissue realm, such as tongue, then the revision becomes difficult and you're not sure you're going to achieve a clearance. So in those cases, we would opt for concurrent chemoradiation. If you have, on the other hand, a bony margin possible, in those cases, if you have not done reconstruction with bone, we would offer the patient a re-revision of the bone margin along with the adjacent soft tissue and then consider adjuvant therapy.
Thank you so much. And Ashwini, regarding depth of invasion, so do you consider the depth of invasion, the cutoff as 10 millimeter for floor of mouth and buccal mucosa as well, or is the cutoff different?
So generally we are considering 10 millimeter as a cutoff. However, in situations where tongue cancer are involved and when the depth is more than 6 or 7 millimeter, and in case there are other poor prognostic factor, then we tend to offer radiotherapy because tongue cancers are much more aggressive, and in those scenario we do offer post-op radiotherapy. In fact, there is a randomized trial going on in our hospital, and it is looking at all oral cavity tumors wherein after surgery the depth of invasion has come between 5 millimeter to 10 millimeter. They are being randomized to receive post-operative radiotherapy versus observation. So such scenarios currently we are requesting them to participate in the trial, and this trial will give us the final answer. But as of now in clinical practice, we take into account the depth of invasion and also presence of other poor prognostic factor and the site of the disease. If it is a buccal mucosa, then we are not worried so much. But if it is a tongue cancer, yes, we are worried, and we tend to give even if it is less than 10 millimeter. Thank you.
Thanks, Ashwini. Just a case scenario, a patient with buccal mucosa cancer, 6 centimeters, depth of invasion 10 millimeters, no PNI, no LVSI, margins clear, 38 nodes removed, all negative. So
Yeah.
will you still irradiate the tumor bed or not?
Yes, the 6 centimeter size itself is large, and with that size, if it is 10 millimeter, definitely we will give post-operative radiotherapy.
So will you include the nodal regions in your low-risk CTV or not?
Yes, we do include ipsilateral nodal region in buccal mucosa cancers, even though neck dissection has been done. And in situation where nodes are positive and 1B nodes are especially positive, we tend to consider low dose CTV as the opposite side neck nodes also, if there is a heavy nodal burden.
Okay, thank you so much. And it's regarding cisplatin 100 milligrams per meter square.
Yes.
Well, in our clinical experience, most of our patients are emaciated when they generally rarely they have a EGFR of more than 60, and we find it very challenging. Would you mind sharing your experience on that?
Yeah, so even though we have done the randomized trial and we have proven that 100 milligram is better, in clinical scenario, not every single patient is able to take 100 milligram per meter square. So as you mentioned, depending on the clinical situation, patient is evaluated, and if found fit for 3-weekly chemotherapy, then only 3-weekly chemotherapy is considered. Otherwise, weekly chemotherapy is considered in our scenario as well. So similar situation is there in our country as well.
Thanks, Ashwini. Thank you so much.
Can I just add one to what Ashwini said?
Yeah.
Ashwini rightly mentioned that our trial didn't actually prove that the weekly chemotherapy improved survival. But if you read into the literature, what we used was a 30 milligrams per meter square. And an effective adjuvant chemotherapy along with radiation should be more than 200 milligrams as a cumulative dose.
Yeah.
So if you achieve that, and in our country, as you rightly said and Ashwini rightly pointed out, patients are not tolerant to a very high dose cisplatin, and they may just altogether stop radiation. So in those cases, if we can achieve at least 40 milligrams per meter square weekly and achieve that target of more than 200 milligrams of cumulative cisplatin, we may still have a survival advantage similar to 100 milligrams per meter square 3 weeks.
Yeah, completely agree. Yes.
One more question, Dr. Professor Ashwini. Do you use cetuximab in a renally problematic patients? Because we are having more side effects like allergy.
Yeah. So in adjuvant setting, we generally do not tend to use cetuximab, but in concurrent chemo radical settings, we have been using cetuximab. But as you rightly mentioned, the mucositis is very intense with cetuximab, and there have been situations where we had to compromise on the total dose when we are giving cetuximab. So yeah, we are careful in use of cetuximab and trying to reduce as much as possible, because in many patients we have not been able to complete the radiotherapy due to the very high toxicity.
Whether you get allergic phenomena, like, because we are getting more allergies and anaphylactic like things. So we drop from the first cycle itself. That is more in head and neck cancer compared to the colorectal cancer in our setup.
Yeah, so rash is quite common, and if the rash is mild, we do continue with the radiotherapy as well as cetuximab, but we have not come across any anaphylactic reaction as such. At least I can't remember of any patient having anaphylactic reaction, but intense mucositis is very, very common, and that leads to interruption of the treatment. And a rash eventually, if we continue on the radiotherapy, then leads to skin desquamation, and very large areas of moist desquamation happen, which lead to not only interruption of the treatment, that healing of that moist desquamation takes a lot of time, and we typically use amniotic membrane to cover that large moist desquamation area, and it takes a long time for healing. So the overall treatment, adjuvant treatment, gets compromised due to all these factors. I agree with you that it is not a simple treatment.
Thank you.
We have one more question from a virtual participant. I think this is to Dr. Pai. The question is, what about the resection extent after neoadjuvant therapy? Is it safe to go with the existing lesion or base it on pre-neoadjuvant tumor size?
So this is an often asked question, and to which we have very little strong evidence. So currently what we practice is based on prior to chemotherapy margins. So we had looked at a small subset, and it has not been proven yet. And we looked at what was the tumor shrinkage pattern following chemotherapy. And we realized that there are tumor rests and nests along the periphery, and you cannot reduce your margins. The reason you gave neoadjuvant chemotherapy was to achieve improvement in vascularity and lymphatic drainage in order to reduce the edema and help you get a better clearance. We know that you have at least a twofold higher chance of getting a negative margin if you have got tumor shrinkage. But that does not mean that you will reduce your margins. So as on today, the dictum should be to stick to your pre-chemotherapy margins.
Thank you very much, Professor Pai and Professor Badruka, for those very comprehensive explanations. Now let's move on to the third speaker of the day, updates in the management of nasopharyngeal carcinoma by Professor Ivan Tham. Professor Tham is a senior consultant radiation oncologist at Mount Elizabeth and Gleneagles Hospital, Singapore. He has special interest in head and neck and lung cancer. He received his training in clinical radiation oncology at the National Cancer Centre, Singapore, and Guy's and St. Thomas's NHS Foundation Trust, UK. He subsequently obtained his fellowship in clinical oncology from the Royal College of Radiologists, UK, and the Royal Australian and New Zealand College of Radiologists. He was previously the head of department and senior consultant at the National University Hospital and the Tan Tock Seng Hospital, as well as associate professor at the National University of Singapore. Dr. Tham has an active interest in clinical research in cancer and has co-authored more than 100 peer-reviewed articles in clinical oncology, radiation oncology, and imaging. Prof. Tham, over to you.
Hi, good day to you. I'm Dr. Ivan Tham, and I'm very honored to be able to contribute to your conference. Today, I'm going to talk about recent advances in the management of nasopharyngeal carcinoma. I'm a radiation oncologist working in Singapore. No disclosures. Pity that I am not able to visit your beautiful country at this moment. And similarly, I hope in the near future I can have a chance to meet some of you participants in Singapore as well and have further exchanges. For the meantime, we will continue with Zoom for many of our interactions. Today's talk, we will look at several aspects of nasopharyngeal carcinoma. First, some points about whether it is an Asian disease, some points about imaging, what we currently do for radiation treatment, whether there's a role for local treatment in metastatic disease. We'll look at a case study and we'll have a summary. So the first question that I have is that what proportion of the global incidence of NPC is from Asian countries? Is it 15, 30, 60, or 85%? I think the answer actually is pretty high. So out of the worldwide incidence of NPC, about 85% of the patients come from Asia. This is data taken from the World Health Organization in 2018. Of that, about 50% of the world's total incidence comes from East Asia, particularly in China. Southeast Asia, where I live and work, we make up about 25% of the global total. So in a word, yes, I would say that NPC is largely an Asian disease. Fortunately, we do know that the mortality rates have been decreasing. We think it could be a lower instance of NPC, which could be associated with a better socioeconomic situation. We think that earlier detection, better imaging, and more effective treatment are all contributory factors to improving the outcomes for our patients. The chart from the World Health Organization shows the year-on-year that the mortality rate for both Hong Kong and Singapore has been steadily decreasing. Next question is that for the typical newly diagnosed NPC patient, which nodes are more commonly involved? Are they the supraclavicular group or the submandibular group? We did a recent analysis of papers looking at this issue. We do notice that nodal metastases in NPC follow an orderly pattern, and the probability of skip metastases is actually pretty low. It is also pretty low. There's also a very low chance that lymph nodes actually spread in a retrograde manner from the level 2 or the retropharyngeal nodes into the submandibular nodes. So we see that less than 3% of newly diagnosed NPC patients actually have submandibular nodal metastases. So the answer for this question is that the supraclavicular fossa is more commonly involved. This nodal map is important because it gives us the possibility of reducing or restricting radiation portals, especially for patients who are clinically and radiologically node negative. In terms of imaging, just one slide. We looked at the papers looking at staging with imaging modalities, and we find that PET-CT is better compared to other modalities for nodal and metastases evaluation. However, MRI of the head and neck is still better for local tumor extent. I feel that imaging is pretty important if we are moving towards more conformal treatments. So I think we want to strive to offer the best imaging possible for our patients before any treatment is started. What do we do currently for our NPC patients with regards to radiation therapy? For the non-clinical or radiation oncologists, treatment planning and delivery of radiation can be a pretty involved process. For the patient, he or she comes for CT simulation and shell mask fabrication, after which we do a CT scan. We do some image processing, bringing in images previously done for diagnosis, such as MRI or PET scans, and integrating that into the CT simulation images that we see. We then can delineate targets as well as normal organs and start planning. We can optimize beam angle, dose, and shielding, etc. Most of this is done with the help of dosimetrists and radiation therapists, as well as pretty fast computers. In the end, we will end up with a topographical map for radiation dose. So for example, in this map of Singapore, we see that the middle of the country is slightly higher, and so it is green, whereas the surrounding areas near the coastline is low-lying and it's purple and blue. Similarly, for radiation dose planning, we can see there are some areas which will receive a high radiation dose, and those in this picture is colored red and purple, and areas which will receive lower doses are in green. In terms of treatment delivery, we generally treat our patients with a linear accelerator. In our hospitals, we have three major models: the tomotherapy, variant, or Electa machines. Essentially, they are broadly similar, and our patients with NPC can be treated on any of these machines. What is more important, I feel, is the daily image guidance that we offer our patients. Every day before treatment delivery, we do a simple CT scan, and based on that CT scan, we can adjust and move the patient position such that we can be accurate to less than 1 millimeter in the critical organs, critical regions. Typically, that would be the clivus or base of skull. In some patients, for example, with bulky nodal metastases, we may actually adapt or replan the patient halfway through the treatment course in case the shape change and so on affects the dose significantly. We generally treat 5 times per week, Monday to Friday, for 33 daily sessions in 6.5 weeks. One point that I think is pretty important is that we need to look carefully at standardization of the target volumes, both for tumor as well as normal organ structures. As radiation oncologists, many of us like to have some kind of consensus, and in the past few years, many consensus guidelines have been formulated for head and neck as well as other regions. So I would advise the younger members of our audience to refresh themselves and to learn the consensus guidelines currently available for head and neck, and particularly for nasopharyngeal carcinoma. Many of our patients also receive concurrent chemotherapy. When we looked at the data from NUH, we see that the majority of our patients had stage 2, stage 3, or stage 4A NPC. All of these patients would benefit from concurrent chemo RT. We might consider a lower dose of cisplatin for stage 2 disease based on a randomized study from China. Patients who are stage 4 might also have some induction chemotherapy first. That has been shown to improve overall survival, and particularly it can reduce the risk of distant metastases. Patients with stage 4 metastatic disease are often best served with systemic therapy first, but there are many patients who then go on to head and neck radiotherapy and radiotherapy to the metastatic sites, which we will discuss later. Recently, there have been randomized studies looking again at the role of adjuvant chemotherapy. And one interesting agent is the metronomic capecitabine, which was given for up to 1 year. In terms of the outcomes, we find that patients with T1 to T3 disease generally do quite well. However, patients with T4 disease, typically intracranial involvement, tend to still have a fairly high local failure rate. So the aim, I think, for us going forward is to try and reduce toxicity for T1 to 3 patients and intensify local treatment for T4 patients. By overall stage, we see that patients in stage 4 are still doing much poorer than patients in stage 1 to 3. And we also find that distant metastasis tends to be the dominant failure mode now. So I think we need to tailor treatment intensification of a systemic therapy to the highest risk groups. How about local treatment for metastatic disease? There is some data, some of which is retrospective, that suggests that reducing the risk of local recurrence or controlling local disease can impact on survival. This benefit is especially seen in younger patients, patients less than 65 years of age, as well as undifferentiated carcinoma patients. The authors think that this could be because the radiation to the head and neck area prevents uncontrolled local disease and prevents new seeding of metastases from the primary site. In our own data, we see that many patients, up to half patients with recurrent NPC disease, die actually from local disease rather than metastatic foci. There might also be a role for RT to metastatic foci. we see in recent years more and more data about the benefit of high dose radiation to oligometastatic sites. And I think the same principles would apply to the NPC patient. We do want to select patients carefully. We look for fitter patients with fewer metastases, typically less than 5. And typically patients with bone metastases tend to do better than those with metastases to other sites. If we do treat, we try to treat with a high radiation dose with SBRT or SABRE techniques. So we'll run through one case that I recently treated. This is a 48-year-old man, previously well, who presented initially with a left neck lump. He was obviously taken aback when biopsy confirmed undifferentiated NPC. When he did a whole body PET CT, not only was the nasopharynx as well as nodal metastases noted, but also metastatic foci were seen at T11-12, left axilla, and the L5. The deposits in the left axilla and L5 were very small. An MRI confirmed that there was also some marrow changes and enhancement in the T11 and T12 vertebrae. My question to the audience is, what would your treatment approach be? Systemic therapy with chemotherapy alone, chemotherapy then head and neck RT, chemotherapy, head and neck RT, and consider SBRT to selected metastatic sites. In this patient, he started with gemcitabine cisplatin chemotherapy. After 3 cycles, PET CT and MRI showed a very good response, as shown by the PET CT scan here. The blood EBV quantitative DNA also dropped very significantly, more than 90%, from more than 2,900 to 265, but it was still detectable. So I had a discussion with the patient and medical oncologist. I felt that the T11 and 12 foci were quite significant in the beginning. So with patient's consent, we delivered SBRT to the T11 and 12 vertebrae. The plan is as shown here. We delivered a dose of 27 grays in 3 fractions over 3 in alternate days. Then we embarked on the head and neck radiotherapy. We looked at the pre-chemo MRI. You can see the bulky level 2 nodal metastasis here, and it does go quite far down. And we looked at our current CT simulation with intravenous contrast, as well as the MRI done after 3 cycles of chemotherapy. So with all these information, we formulated the treatment plan and volumes for both target as well as normal structures. We planned for a dose of 70 grays in 33 fractions over 6.5 weeks. Actually, we typically don't run chemotherapy in patients with metastatic disease just to reduce the toxicity. But on patients' request to have maximal treatment, we actually then offered concurrent weekly cisplatin. Patient tolerated treatment pretty well. And actually about 3 weeks post-RT, repeat blood EBV quantitative DNA was undetectable. We had a discussion about whether to embark on SBRT to the remaining 2 metastatic sites in the axillary node, as well as the L5. Those 2 sites responded very well on PET CT after just 3 cycles of chemotherapy. And if the DNA is undetectable now, I think we can probably watch for now, but this is a discussion point certainly. So to summarize, the treatment approach for our patients with NPC depends on the biopsy, confirmation that this is indeed cancer, as well as staging investigations. Stage 2, 3, 4A patients generally get concurrent chemo RT. Stage 1 patients get RT alone. Induction chemotherapy is certainly a viable option. I would discuss that as a preferred option actually if the baseline or pre-treatment EBV DNA is quite high. So that denotes, to me, a high chance of metastatic disease, which is microscopic, in which case I think induction chemotherapy has a good role to play in this setting. Adjuvant chemotherapy is also something we do bring to the table now, and that's also something we can discuss with the patient. In terms of stage 4B patients, I think the first treatment should still be systemic therapy, but we need to stay involved and offer a head and neck RT, as well as possibly RT to metastatic sites to appropriate patients. So to summarize, the cure rate for NPC is improving, but I would say large local disease, especially those with intracranial involvement and distant metastases, remain problematic. Toxicity is more manageable with IMRT compared to older techniques of radiation, but at the same time, it is difficult to spare organs which are invaded or just adjacent to tumor. Again, specifically intracranial involvement. I would say that RT may have a role in metastatic disease, and that can also translate to improved overall survival for our patients. So with that, I thank you. Welcome you to Singapore when the situation settles down and travel returns to normal. Yeah, I would welcome any questions from the floor. Thank you.
Thank you, Professor Tom, for that informative lecture. And I would like to thank all the international speakers who joined in the first symposium. And as we are going behind the schedule, I would like to conclude this symposium. And if there are any more questions, we will contact Professor Pai and Professor Ashwini through email to forward your questions. And we will move on to the first plenary of the day on management of advanced peritoneal carcinomatosis. And it's my honor to introduce Professor Sarah Odwyer. Professor Odwyer is a highly experienced consultant surgeon with an international reputation on her work in the areas of colorectal disease and peritoneal malignancy. She's a graduate from the University of St. Andrews and the Victoria University in Manchester. She was awarded a research fellowship at Harvard University, USA, and traveling fellowship to New South Wales, Australia, the Mayo Clinic, and Minneapolis, USA. Her first consultant post in 1992 was at the University Hospital, Birmingham, and she took up her current post at the Christie in 1995. Her work in the field of colorectal peritoneal metastasis was awarded Cancer Care Team of the Year in BMJ Awards in Macmillan in 2013. Professor Odwyer has actively engaged in clinical management to improve services regionally and nationally, and has awarded by the NHS for the support in national commissioning of services for pseudomyxoma peritonei, colorectal peritoneal metastasis, and robotic surgery. Over to you, Professor Odwyer.
Ladies and gentlemen, thank you and thank the committee for inviting me to address the conference today. I hope you're having an excellent conference, and I'm really sorry I can't be with you in real time. I have been asked to talk on the management of advanced peritoneal carcinomatosis. However, I would like to eliminate the word carcinomatosis from your vocabulary in this regard, and I would suggest that we should use the term the management of peritoneal surface malignancies. This is essentially because carcinomatosis has the connotation of being a palliative, untreatable condition. And I hope as this talk goes on, you will appreciate that this is not the case for peritoneal surface malignancies, that we can actively treat and get excellent results using advanced surgical and intraperitoneal chemotherapy. So the commonest source of peritoneal surface malignancies comes from the appendix. There's been lots of terminology over the years, but we now use the terms low-grade appendiceal mucinous neoplasms as the driver of the significant surface malignancy, which has been described as diffuse peritoneal adenomucinosis, i.e. pseudomyxoma peritonei. Also, there are appendix true adenocarcinomas and goblet cell carcinoids, which really are not carcinoids, but are adenocarcinomas in their own right, but have a different profile. In addition to the appendix lesions, of course, there are surface malignancies that originate in the colorectal, gastric, pancreaticobiliary, ovarian, primary peritoneal, and mesothelioma. I won't obviously be able to cover the entire spectrum today, but we will focus on some of the key areas. The reason why we focus on a few key areas is that in the United Kingdom, cytoreductive surgery and HIPEC is confined to a very small number of centres. There are disadvantages to this, but there are also advantages in that we end up with a large caseload. Now, in England, we are licensed to treat pseudomyxoma, appendiceal neoplasia, and colorectal peritoneal malignancy. We aren't at the moment licensed to treat ovarian cancer, but we are actually currently devising a pilot for that. We don't get funding for gastric and mesothelioma. The different centres refer to each other. Wales don't treat colorectal peritoneal metastases. You can see from the graph there the distribution of cases that we get from throughout the United Kingdom, but we also get some cases from Europe and beyond. Because of the license to practice, our pathology reflects the case mix, and you can see that just over half are low-grade appendiceal mucinous neoplasms or pseudomyxoma. A quarter are colorectal, and then the more advanced true adenocarcinomas of the appendix that clearly have become a significant component now of our pathological profile, and the rarer goblet cell carcinoids. Now, when we talk about pseudomyxoma peritonei, most are primary appendiceal pathology, and as we've talked about, the LAMs. However, rarely you can get PMP arising from a primary GI or biliary mucinous carcinoma, but commonly they are mistaken and treated as ovarian primaries. And there are a number of cases we see, even to date, that have had chemotherapy for ovarian cancer, but actually do better than expected. And then on review, we would recognize that it's an appendiceal primary. So how do they present? Well, here's a classic radiographic picture with the appendix here, the cecum, the appendix, and a large mucocele. In real life at operation here, we can see the appendix from the cecum and the mucocele, but this is now ruptured, and you can see there are small areas of mucus outside of the mucocele, which will go on to promote pseudomyxoma. The natural history is quite interesting, and here's a radiograph of a patient taken in 2011, and she has a small appendix mucocele, the appendix normal there and the mucocele just below. This was not treated, it was left in situ, and in 2 years this is how she now presents with mucinous fluid around the liver and large ovarian implants with more solid disease in the left palancolic gutter. So this was a 2-year time frame. It can be up to 10 years. It varies, but clearly, if left untreated, inevitably it will go on to develop PMP. So advanced PMP, and anybody who starts a program will see cases like this. Obviously, this gentleman has a massively distended abdomen. He is cahectic. He has lost its lean body mass. And obviously, this is a pretty awful situation. The CT scan can demonstrate a large amount of free mucin, but also solid amental caking. And the small bowel and colon are pushed over to the side and squashed. And so this is why the patient becomes emaciated and actually ultimately starves to death. In the advanced stages, of course, you can see this classical, what's called scalloping of the liver, where there is multiple hard indentations into the liver, and in the left upper quadrant, again, scalloping of the spleen and enclosing the stomach. Morphology can vary, and this was a young patient with a solid amental cake, and you can see here we had to open all quadrants of the abdomen simply to actually get at the amental cake and lift it out in this young patient. So appendix carcinoma is macroscopically different. You can see here the normal appendix and then this bulbous change to the appendix, which is solid and not a mucocele. This is a carcinoma. It tends to present with more solid amental deposits similar to colorectal peritoneal metastases. But classically, again, you get large ovarian metastases, which will progress and can often be extremely symptomatic in patients if left untreated. Colorectal cancer, of course, now we recognise as being a source of peritoneal metastases. The classic sites are well described, and it's only perhaps in the last 10 years that people have started to concentrate on the peritoneum as being an area that actually deserved treatment in its own right. The interesting thing is when you look at the survival of patients with colorectal metastases, the blue line here shows patients with lung metastases, the orange with liver metastases, and of course, people with peritoneal metastases traditionally do significantly worse with a median overall survival. This is a relatively new publication of only 16 months if left treated or just given standard of care with regard to palliative chemotherapy. Now, a lot of the management of colorectal metastases were predicated on this randomized trial from the Netherlands, which actually published the 8-year follow-up of patients who had cytoreductive surgery and HIPEC, as opposed to standard of care and standard treatment. And clearly what they showed was that there was a 25% 5-year survival in these patients, as opposed to the patient who had the standard systemic palliative chemotherapy, where there were no survivors at 5 years during that 8-year follow-up. Obviously, there have been a number of studies in the intervening years, and a meta-analysis here demonstrated that there was a survival advantage to offering cytoreductive surgery and any form of intraperitoneal chemotherapy for colorectal peritoneal metastases. This led to a series of guidelines. In 2015, we published the international guidelines, which demonstrated that cytoreductive surgery and HIPEC was considered then to be the standard of care for PMP and for colorectal peritoneal metastases, provided you could get a complete cytoreduction, and highly selected patients with gastric cancer may benefit, but that has been questioned subsequently. In 2016, the European Society of Medical Oncology published their guidelines, and at that point they said it is on the verge of becoming the accepted standard treatment for patients from colorectal primaries, but complete cytoreductive surgery can be considered in centres which are very experienced in the use of HIPEC, and we'll talk about experience in it. So what do we mean by experience? Well, this demonstrates our caseload over a 20-year period, and the orange patients are the referrals, the blue are the ones that we've operated on, and you can clearly see an exponential increase here in appendix tumours over that period of time. A much slower lag for colorectal, because actually we were only officially allowed to treat colorectal patients in 2013, and again you can see an exponential rise in the referrals. A sort of standardization about the number of patients we operate on, and I'll talk about that in a little while. So how do we select patients for this procedure? Well, we have a dedicated MDT for peritoneal tumours. Obviously, this is pre-COVID, where we had lots of paperwork and lots of people sitting together. That's obviously changed now, and we do most of our MDTs virtually, although it's not as good. Just a little data to share with you about a study we did on the MDT outcomes of patients who were referred, and this was published in 2018. Just under 300 patients were referred, and 117, that is 40% of them, underwent cytoreduction and HIPEC. Now, how did we decide about which patient should be offered it and which patient shouldn't? So interesting, the MDC decision was 60% were advised against surgery. Why? 40% because of the extent of the peritoneal disease, i.e. we wouldn't get a complete cyto. 28% because they had active systemic disease, i.e. nodal disease that needed treating with chemotherapy. Just over 10% had progression on chemotherapy. Only 10% were thought to be unfit for surgery. Obviously, there's a selected group of patients already referred in, so they may have been selected before they got to us. And a very small percentage actually refused the treatment. So in summary then, no cytoreduction in just under 60% of patients who were referred, but there was a range depending on the time. And I thought this was an interesting data set to share with you, that actually in the first period, we were offering the surgery to almost 65% of patients. In the mid-period, this had reduced to 40%, and now it's around about 30 to 35% of patients who are offered it. So we've become far more selective over the years. What does that assessment involve? Obviously, dedicated involvement from all the specialty areas. We also have specialty anaesthetists and supportive care. We take careful consideration, yes, of age and comorbidity, what prior treatments the patients had, but very importantly, what is the aim of our objectives? Are we trying to cure the patient, or are we just simply trying to contain the disease? So obviously we do very thorough assessment and recording of the comorbidities. We have a dedicated pre-operative assessment team. We will do our best to get excellent diabetic control. We obviously need to know about renal function, drug and alcohol. We do a lot of work on smoking cessation. And in PMP in particularly, we will offer a prehabilitation program for patients to actually improve their general health before actually embarking on major surgery. Obviously, we'll become familiar with terms like the peritoneal cancer index, which many of you will be aware of, but involves a maximum score of 39. We do know that this matters because in scores of less than 12, we can usually get a full cyto reduction. For appendix cancer, if it's less than 10, there's a 50% survival. And in colorectal cancer, if it's greater than 20, it's generally a poor prognosis, as it's unlikely you will get a complete cyto reduction. So carrying on with the patient selection then for PMP, we don't want to make them worse. We will give a surgical approach for patients with a range up to 39 in PMP. We will modify it according to age, and some patients in the elderly age group, we would offer a debulking with removal of the appendix, the ovaries and the omentum. We sometimes do a two-stage approach if there is a large volume in the upper abdomen and the pelvis. And again, we're trying to decide, are we curing this patient or are we merely containing the disease? So what's the difference between carcinomatosis, as I told you, to remove from your vocabulary, and metastases? Basically, where there is massive systemic disease, as seen here by significant lymphadenopathy in the retroperitoneum, a non-functioning kidney because the ureter has been obstructed by disease at the pelvic brim, this would not be a patient that you would offer cytoreduction. Where there is massive small bowel involvement with miliary disease, as demonstrated here, we did a case just earlier this week, which was a goblet cell carcinoid of the appendix that looked just like this. And the radiograph will show you thickened loops of serosal disease in this sort of pattern with the surrounding omentum and ascites. And these patients will have a solid omentum as looks in this particular picture, and that is not curative. What about where there is significant small bowel involvement? Well, you can get multi-level obstruction like here. If it's contained to 1/3 of the small bowel loops, then it's probably resectable. If it looks like this, one worries that there is infiltration of the mesentery in the lymphatics, and we would offer laparoscopic assessment in these patients in order to determine the extent of the small bowel disease. So what about where there is colorectal peritoneal metastases in the presence of liver metastases? Well, as you can see here, these patients can be a challenge. But what we do know is that if the PCI is less than 20, no comorbidity, and small volume liver disease, we would offer that approach. Curative attempts at colorectal liver metastases. This is from the French group. I want you to concentrate on the red line and the purple line here. And the red line is where there is a small number of liver metastases, and they get as good a result as where there is a PCI of less than 15. And so basically those sort of patients are the ones you want to try and pick out and see whether you can offer them a curative approach. So to summarize, for colorectal and appendix cancer, less than 20, no involved lymph nodes, potentially curable liver and lung lesions, and the absence of multi-level small bowel obstruction. What's the principles of management then? Remove all the peritoneal disease, remove the at-risk organs, the target organs, the omentum, gallbladder, falciform ligament, resection of the involved viscera, and completeness of cytoreductive score that you're trying to achieve. And then when you've done that, you want to actually offer the chemotherapy. So cytoreductive surgery is surgery that goes from the diaphragm to the pelvic floor, and you have to familiarize yourself with all of these techniques. Just some clinical pictures. This is the peritoneum that's been stripped from the diaphragm. You can see lots of mucinous deposits here, reflecting off the liver and the falciform ligament. When that's reflected forward, you see the bare muscle of the diaphragm, and that peritoneum can be taken off, hopefully in one piece rather than as a string breast. You skeletonize the omentum from the greater and lesser curves of the stomach, and you're looking straight down on the anterior reflection in the lesser sac of the pancreas. Once you've actually done the full cyto, we then offer the intraperitoneal chemotherapy. We traditionally use the Colosseum technique, and we're very keen to actually put 4 thermistors in the different quadrants of the abdomen so that we can actually equilibrate the temperature of the circulating chemotherapy, which is crucial to its distribution. We now use a closed technique since COVID to avoid any aerosol generating dissemination. So what drugs do we use? Well, generally for PMP and appendix cancer, we use mitomycin C. For colorectal cancer, we have been using 5-FU and oxaliplatin, although that might be something that we'd have to discuss because of the results of the Prodigy 7 study. For gastric, ovarian and mesothelioma, cisplatin and doxorubicin are the drugs of choice. So what are we trying to achieve? We're trying to achieve cytoreductive scores of 0 or 1. And here you can see for our appendix tumours, we achieve this in almost 80% of patients, and similarly, more than 75% of patients for colorectal peritoneal metastases. And that really is a reflection on how well you are selecting the patients. And I think it is something one needs to monitor as you develop programs. What about the complications? Well, as you can see here, this is a publication, a little bit old now, 2007, but in the large volume centres, the mortality is kept quite low, but there are a significant incidence of major complications. And our series, you can see here from up to 2017, just under 1,000 patients, 15% major complications and less than 1% mortality. And obviously we feel we've managed to achieve that with the experience of the team over the years. So what do we achieve with regard to survival? Top graph PMP, the blue lines are complete cyto, the red lines are incomplete cyto, and you can see PMP patients do extremely well. Appendix adenocarcinoma, survival around about 50% at 5 years. Colorectal, about 30% survival at 5 years. So basically, there is an advantage to offering this in the right patients. What about gastric cancer? Well, just share with you another meta-analysis where again it showed that there was a survival advantage to offering this. This was done in 2014. However, the groups that are actually offering it now are trying to do what we call neoadjuvant intraperitoneal and systemic chemotherapy, that's NIPS for short, where basically there is a sandwich type of treatment where they do neoadjuvant intraperitoneal chemotherapy administered with a port, followed by systemic chemotherapy, followed by neoadjuvant intraperitoneal again. And using these techniques, the groups, particularly in Japan, have shown a difference between the patients who are having the NIPS for 5 year survival of 20% versus those that aren't of only 5%. So clearly there is more to learn in gastric cancer. What about ovarian metastases? Well, New England Journal of Medicine has shown that there is an advantage to offering HIPEC for patients with ovarian cancer who have had cytoreductive surgery. There were no increase in complications in the patients who had HIPEC in that study. Now, everything was going very well before COVID, but we can't blame COVID for everything. But just when you feel you've got things under control, something comes along, just like COVID, and hits you between the eyes. So here, obviously, it was the publication from the French group who did the randomized trial of cytoreductive surgery plus HIPEC for colorectal peritoneal metastases. In summary, I've put there what their implications were from the results of their study, was that they declared that high-dose oxaliplatin-based HIPEC given over a short duration should no longer be used, and macroscopically complete cytoreduction should be considered the mainstay of treatment for colorectal peritoneal metastases as opposed to HIPEC. I haven't got time to debate that, but we are currently undergoing an evidence review for all peritoneal tumours, and we're assessing the evidence for cytoreductive surgery versus cytoreductive surgery with HIPEC for ovarian, colorectal, gastric cancers, and we're evaluating the clinical effectiveness and the cost effectiveness, and we should be able to publish that next year. Just a quick word about training. What you need to know about training for developing a program. I just share with you some studies from the literature, and what these show is that procedure-related morbidity ranges significantly according to your experience, as does mortality, and it's overall over 100 cases are required for what we would call proficiency of running a program. And so don't underestimate the amount of experience you need to actually run a program safely. There is a European training program of which we're very involved. I would suggest that if you go to the website, you can actually look at what is required for that training program. And if you're developing a program, perhaps you might want to use this as a model. I think it's a very good model for units to actually adopt. Fellows who come to us receive a certificate after their 12 months, sorry, not 12 years, working with us, saying that they've achieved a competency in colorectal and peritoneal advanced malignancy training. What's the future? Well, we believe very much in education and research, and this is a new building that's taking place. It started this year in 2021. That's what it looked like in January. It is actually going to look like this in 2024, and hopefully it's going to be a showcase for education research at Christie, and hopefully we can share some of our experience and knowledge.
Thank you very much, Professor Dwyer, for that very interesting presentation. Professor Dwyer is joining us virtually now. We are very much grateful to you for your presence today with us, especially despite the time differences of our countries. And now we are open for questions from the audience.
Professor Odwyer, I'd like to ask, at the same time, if you find in colorectal cancers, if you find metastasis in the liver, do you remove them or they excise them at the same time, or do you do it in a different setting?
Thank you. Yes, I did touch on that. There's a couple. Hopefully, the slides will be available to the participants for their reflection. It's very important to actually stage the quantum of the disease. If you've got low volume liver metastases and relatively straightforward peritoneal metastases, then it's perfectly safe to do both together. But if you've got large volume in either compartments, then it's probably better to do it in a staged manner.
My second question is, do you think doing laparoscopy before the procedure rather than doing PET scan? Because we found that some of the PET scans and MRIs, they couldn't find any peritoneal disease on imaging.
Particularly for mucinous tumours, PET scans are notoriously unreliable. So you can't actually use PET scans, and you need to, be very careful about the histological subtype. As I've indicated in the discussion there in the talk, we do use selective laparoscopy, particularly if we're trying to evaluate the extent of small bowel serosal and mesenteric disease, and it is a useful tool. But obviously, you often find when you're actually doing these programs that patients have had numerous operations before. Sometimes they've had emergency surgery, and basically that can limit what you can actually evaluate laparoscopically. But we are actually quite keen to offer it, even if we accept that there are limitations to what laparoscopy will tell you. But it can help both the patient and yourselves in actually being able to inform the patient why they actually should not go ahead to have complete cytoreduction, because basically often these patients are clutching at straws, and you need to actually be able to differentiate those that you can actually do something valuable for and those that can't. So selective use of laparoscopy is very useful, particularly in mucinous tumours.
Thank you.
We have a couple of questions from our virtual participants. One is, while literature supporting the place of CRS and HIPEC for peritoneal disease in recurrent ovarian cancer, is there a special reason why it is not yet practiced in UK?
Well, we have a very, as you're probably aware, very strict financial situation with the National Health Service in the United Kingdom, and they have an organisation called NICE, which evaluates treatments on a regular basis with regard to its cost effectiveness. And obviously they were waiting for the randomised trial, which was published, that I alluded to in the discussion, in the talk, in 2018, where that was the first randomised trial for ovarian cancer that actually demonstrated a difference for adding in HIPEC as opposed to cytoreductive surgery alone. Interestingly, there's another equivalent trial from Korea that actually has yet to be published, but I've seen the data and they haven't shown a difference with HIPEC. So there is still some debate as to sort of whether it actually is cost effective and or effective clinically. We actually have just started a pilot at the Christie for HIPEC in ovarian cancer. My personal view is that the variation in quality of cytoreductive surgery in ovarian cancer is such that the actual surgery needs to be standardized prior to actually adding in HIPEC. And only then will we actually be able to know whether actually it is truly effective in ovarian cancer. And so that's the reason, is that we have a very regulated system. I think that's a good thing, in that ultimately we can actually then quantify the different interventions.
There's another question from a virtual participant. For recurrence within short period following CRS and HIPEC, what is the place for re-HIPEC for LAMN?
Okay, well, we've actually recently published, I think earlier this year, we published our series of repeat cytoreductive procedures. And it's in the European Journal of Surgical Oncology. If somebody wants to reference it, Sutton et al. And it's quite an interesting publication, because it actually shows you the benefit and value of repeat site reductive surgery in the different pathologies. And we have shown that certainly in PMP, it can be actually very, very effective. For selective colorectal, it is also effective, less so for other pathologies. But yes, there is a place for it. If it's localized to probably three areas, then it is very useful in colorectal. But if it's disseminated, it probably isn't. And I would refer you to that publication, European Journal of Surgical Oncology.
Thank you very much for those comprehensive explanations, Professor Dwyer. And once again, thank you very much for joining with us, even though it's very early morning for you there.
Thank you. Yes, it is. Have a good day.
Yeah.
Bye now.
Up next on the schedule for today is the plenary on radiotherapy on medulloblastoma, delivered by Dr. Thankamar Ajit Kumar. Dr. Ajit Kumar is a consultant clinical oncologist at the Cambridge University Hospital. His specialty interests are pediatric radiotherapy, radiotherapy for hematological malignancies, and management of hepatobiliary and pancreatic tumors. He is the chair of the European Society of Pediatric Oncology Brain Tumor Radiotherapy Group. He has been the lead editor or co-editor for 5 oncology textbooks, Specialist Training in Oncology, Oxford Desk Reference in Oncology, Oxford Case Histories in Oncology, and Imaging in Clinical Oncology. Over to you, Dr. Ajit Kumar.
Thank you for asking me to give a talk on medulloblastoma. Even though medulloblastoma can occur in all age groups, it is most common in children. %80 of tumors occurs in children aged less than 15 years, with a median age group of 5 to 6 years. It is typically a midline posterior fossa tumor, and 1/3 of patients will have CSF spread at diagnosis. In comparison, the median age in adults is 29 years. Metastases are less common in adults, and the commonest site of metastasis outside the brain is lung in adults and liver in children. The time of relapse is also different in adults and children, with 75% of recurrences in children occurs within 2 years of treatment, whereas in adults, more than 45% recurrences occur after 4 years. The initial management include investigation and surgical resection. A postoperative MRI scan is needed to assess the residual tumor and should be done within 72 hours. The spinal staging can be done either before surgery or 10 to 14 days after surgery. The postoperative treatment depends on the age and risk group. There are 2 risk groups based on the Chang system, and this risk grouping is based on age, residual tumor, and metastasis. Some people also add anaplastic and large cell histology as high risk group. As you can see, the overall survival is better in children aged more than 3 years. A 2018 SEER study has shown that there is no difference in survival between adults and children based on the risk group. What is the current management of children aged more than 3 years? There are 2 studies support the current approach. The Packer study, which evaluated 23.4 Gray, followed by boost radiotherapy to posterior cranial fossa and maintenance chemotherapy. This yielded a 2-year progression-free survival of 80%. The CCG study kept the same radiotherapy dose as in the Packer study, but compared maintenance chemotherapy regimens. However, the survival was not affected by chemotherapy, and both studies show an event-free survival of approximately 80%. The PNET4 study looked at altered fractionation. So this study compared 23.4 Gray craniospinal artery with a hyperfractionated radiotherapy of 36 Gray given in 1 Gray twice daily fractionation. However, this study failed to show any improvement in clinical outcome. And therefore, 23.4 Gray craniospinal artery followed by boost radiotherapy followed by maintenance chemotherapy remains the standard of care in standard risk medulloblastoma in children. In high-risk medulloblastoma, there is one phase 1/2 study which evaluated 36-gray CSA followed by a boost. The concurrent chemotherapy was given as weekly vincristine carboplatin, and it reported a progression-free survival of 70%. And in this study, as you can see in the graph, the anaplasia was a negative predictor of both progression-free and overall survival. There are two studies of altered fractionation in high-risk medulloblastoma, which did not show any improvements. However, the Milan study, which showed a progression-free survival of 72%, since it is a hypofractionated study, it is thought to improve the long-term toxicity and therefore will be one of the comparison arms in the upcoming European high-risk study. Nevertheless, 36-gray craniospinal RT followed by posterior cranial fossa boost with concurrent chemotherapy followed by maintenance chemotherapy is the current standard of care. So how is medulloblastoma managed in adults? There are no prospective studies of radiotherapy in adults, and both risk groups receive higher dose of CSI similar to the pediatric high-risk group. Role of chemotherapy is not well proven. There are two prospective small studies which were inconclusive. The HIT study and a meta-analysis from the Rare Cancer Network did not show any improvement with the addition of chemo. However, a larger meta-analysis of 227 publications involving 907 patients showed a mean overall survival of 108 months with chemotherapy compared with only 57 months if no chemotherapy was given. A national cancer database study also confirms the benefit of chemotherapy with a 5-year overall survival of 86% compared with only 72% without chemotherapy. Therefore, the current recommendation in adults is 36-gray craniospinal RT with a posterior cranial fossa boost followed by maintenance chemotherapy. The management of infants are quite different. Due to the high risk of radiation toxicity, chemotherapy-only approach is usually being used with avoidance or delaying of radiation treatment. And most studies, unfortunately, report a 5-year progression-free survival of 30 to 50%. Except one study, the HIT-HKK study, which has an addition of intraventricular methotrexate, which reported a 90% progression-free survival. The Censured infant medulloblastoma study categorized patients according to metastasis and histology as low risk, intermediate risk, and high risk. And the children were treated with chemotherapy with or without focal radiation treatment. And this is the outcome. The overall 5-year event-free survival was poor with 30%. However, the event-free survival of low risk was 55%. A subgroup analysis of this study identified two subgroups of the SHH molecular group based on distinct methylation groups. As you may see, the SHH type 2 had an improved progression-free survival of 75% in the absence of radiation, intraventricular chemotherapy, and high-risk chemotherapy compared with the SHH1 group. This has led to a newer classification of infant medulloblastoma, where the risk group is modified taking into consideration of molecular features and metastasis. Radiotherapy has been the cornerstone in the management of medulloblastoma. Attempts has been made to reduce the toxicity, either using reduced dose or volume of radiation treatment or adoption of proton therapy more recently. Since modern radiotherapy uses a volume-based rather than a field-based approach, there is no clear guidelines. Therefore, the SIOP in Europe has produced a consensus on target volume delineation. A number of studies evaluated less than posterior cranial fossa volume. The most important study is the ACNS 0331. In this study, the The CTV for boost volume was tumor bed plus 1.5 centimeters, and it reported the same survival as that of the posterior fossa volume. And this is more than 80% in both arms. And this finding was confirmed by the subsequent French study of MSFOP98 and 2007. Therefore, the small volume boost is acceptable in standard risk. However, there are no conclusive evidence of smaller boost volume in high risk, except a small study of 10 patients reported last year, which showed acceptable acceptable survival similar to a posterior fossa volume boost. The ACNS 0331 trial also evaluated reduced dose craniospinal radiation in the standard risk. The patients were randomized between 18 gray and 23.4 gray. As you can see on the graph and the 5-year survival figures, the lower dose in fact resulted in an inferior survival with increased risk of relapse rate. So currently a reduced dose CSI in Chang classification is not acceptable. Reduced dose CSA has been evaluated in smaller studies. For example, this is the study from Japanese Pediatric Brain Tumor Consortium reported last year. It suggests that reduced dose can be equally effective, but it is not accepted as a standard of care. Proton therapy has been increasingly used clinically. One prospective study of proton therapy from Harvard reported similar outcome as that of photons and a potential improvement in toxicity. There are at least 2 retrospective studies also report similar survival as that of the photons. However, there are no studies comparing photons with protons, especially in terms of late toxicities. In Europe, we did a comparative study of field-based treatment with IMRT, BMAT, tomotherapy, and protons from 15 institutions in total. As you can see on the left-hand side graph, the volume-based techniques gave a better conformity index than the field-based techniques. However, the organs at risk doses were different with different techniques, with the lowest being with protons. Generally, most techniques give less than 10 gray to organs in the body. Since we don't know the true impact of difference of doses below the tolerance of organs, it is difficult to recommend one technique over another. However, as we know, the BMAT and tomotherapy has the advantage of avoiding field matching. 2 aspects which affects outcome following radiotherapy are the total duration of treatment and delay in treatment. If the duration is more than 50 days, it compromises the survival as in the Polliner study. Similarly, a delay in starting radiotherapy beyond 49 days compromises survival in the PNET4 study. Therefore, radiotherapy should start within 40 days and the duration should be ideally kept less than 50 days. I mentioned earlier about the SIOP guidelines. As you know, for craniospinality, the CTV is the CSF space. And we did 2 studies to look at the extent of CSF within the skull base and dural sheath. For example, the picture C highlights CSF in the dural sheath. As you can see, the CSF in the dural sheath extends up to the cochlea. And therefore, we should be careful when we are trying to spare cochlea in situation like this. And we also found CSF in all the skull base foramen, which is extending up to 8 to 10 millimeters from the inner table of the skull base. In the spine, there was no extension of CSF within the sacral foramen, and therefore the traditional practice of treating a spade-like field is not needed. We have developed a guideline and an atlas. which is being adopted for our standard clinical practice and future European trials. The most important development in medulloblastoma is our understanding of the molecular pathology. Based on genomic-wide transcription profiling, there are 4 different molecular subgroups of medulloblastoma: wingless, sonic Hedgehog, and groups 3 and B, 3 and 4. They differ in radiological and clinical pathological features and the response to treatment and survival. For example, this is details on the wingless subgroup, which is very sensitive to chemotherapy, possibly due to a hemorrhagic vasculature that lacks blood-brain barrier. It has got an excellent survival, and therefore the current trials are attempting to de-escalate treatment in patients with wingless subgroup. The SHH group rarely disseminates and has a similar outcome in all age groups, and studies are currently attempting to de-escalate treatment. The group 3 is rare in adults, has a poor outcome, but they are particularly sensitive to pemetrexate, gemcitabine, PI3 kinase, and mTOR inhibitors. And one of the Senju studies now evaluating these drugs in this particular subgroup. The group 4 is the common subgroup in children. It has an excellent survival outcome. Even though we have 4 pathological subgroups and 4 molecular subgroups, as you can see in this picture, there is no correlation between the classical histological group as well as a molecular subgroups. However, the molecular grouping is no longer based on the Chang system, but heavily depends on the molecular features of the molecular features. And now it can be divided into 4 subgroups like low risk, standard risk, high risk, and very high risk. One of the challenges, there is no unified risk group which are being adopted for clinical trial. For example, this is the Senju criteria for current clinical study MB-12. And the wingless and SHH are grouped into one subgroup. They are categorized as low risk, average risk, and high risk. And the group 3 and 4 are categorized into average risk, intermediate risk, and high risk. Whereas in the SIO, the wingless group is entirely separate, and age is an important factor in SIO group because children with wingless positive tumor with more than 16 years has a poorer prognosis than children less than 16 years. Therefore, they are classified as standard risk. Like any other field, there are novel drugs in medulloblastoma, which is mainly targeting the sonic Hedgehog group, which is a dominant subgroup in all age groups. And a phase 1-2 study of a Hedgehog inhibitor, sonidegib, showed that in an unselected group of people, it results in a 3.3% response rate in children and 18.8% in adults. However, if you specifically look at children and adults with sonic Hedgehog positive tumors, the response rate is 50%, with 40% achieving a complete response. These are the examples of excellent response in 2 patients, and the first and second patient showing a complete response with continuation of treatment using sonidegib. However, the studies reported an unexpected side effects. In humans, there are 3 Hedgehog receptors: sonic, desert, and Indian. The desert receptor is seen in gonadal and muscular system, that way people can get the muscular side effects. The Indian Hedgehog receptor is seen in chondrocytes. The current Hedgehog inhibitors affect all receptors. And in children who has not completed growth, these drugs can cause premature closure of the epiphyseal growth plate. As you can see in the picture A, all the epiphyseal plates are being opened before the start of the treatment. In the middle of the treatment, say for example, it started closing in the distal femur and proximal tibia with the proximal fibula plate is not closed, but when the treatment is continued, the joints are completely closed in all the joints, and this is likely to cause growth impairment in children. Another HCO inhibitor is vismodegib. This is being studied in adults in the Movitum trial for patients with recurrent refractory medulloblastoma in adults. This is compared in combination with temozolomide versus temozolomide alone. Unfortunately, the study was a negative study as it failed to improve the progression-free survival at 6 months. Which begs the question whether sonidegib and vismodegib are equally effective. There is one meta-analysis which compared the efficacy of both drugs. It should note that while in adults there is no statistically significant difference in the efficacy between two agents, in children, sonidegib has a 3.67-fold higher effect, possibly due to the better penetration of these drugs. But as I have previously said, the problem is you have to avoid these drugs in children who has not completed cure. So what are the ongoing clinical trials in medulloblastoma? There are trials for all age group. Infants, there are 2 trials, SIOP and Head Start 4. Children more than 3 years, there are enough trials, and in adults. For example, the ACNS 1422 trial, which is an American trial evaluating de-escalation in the wingless group. This study is reducing the craniospinal artery to 18 gray and reducing the maintenance chemo. And for the first time, there are 2 prospective studies in adults. The RSMA 2010 trial in standard risk is evaluating a lower dose of radiotherapy of 24 gray. There is an European infant study in setup. In this study, radiotherapy is based on risk, and children will not be given any radiotherapy until 18 months. And we use temozolomide to postpone radiotherapy, and the radiotherapy dose is craniospinal is either 18 gray or 23.4 gray. This is the complicated stratification of PNET5. In summary, the wingless positive disease in less than 16 years are categorized as low risk. They get 18 gray craniospinal artery with a 50 gray to the tumor bed boost without any vincristine, and this arm has already completed recruitment. The other groups receive 23.4 gray craniospinal artery, but the randomization is between no concurrent chemotherapy versus carboplatin chemotherapy. The SIOP high-risk study compares 3 approaches from previous results. The hyperfractionated accelerated radiotherapy in the Milan strategy, which I have already mentioned, and the tandem use of high-dose chemotherapy with autologous stem cell transplantation, and the role of induction chemotherapy. And this is the design of the high-risk medulloblastoma study, which just started recruiting. Patients receive induction chemotherapy, then there is a randomization into standard arm, high-risk arm, or high-dose chemotherapy followed by standard radiotherapy arm. And there is also a randomization between the standard maintenance versus temozolomide-based maintenance. This is the first adult prospective study based on molecular targeting, and there are 3 subgroups, and what essentially this study was looking at is the use of HCO inhibitors as a standard. This is the current management of children with medulloblastoma outside the trial. Infants have a chemotherapy-only approach with delayed RT upon progression. And for children with standard risk, it is 23.4 gray with maintenance chemotherapy. And for high risk, it is 36 gray followed by chemotherapy. This is a recommendation from the European group. In adults, both groups, the standard radiotherapy is 36 gray in 20 fractions craniospinal axis. However, they have put an option of giving a reduced dose of craniospinal artery in adults with intermediate risk disease. However, challenges in management of medulloblastoma remains. Even though molecular subgrouping has known for last 1 decade, we are still started using in clinical trials. And it may take another decade or so before this will become a routine clinical practice. There are significant differences in the molecular characteristics even within a subgroup, or at recurrence or in the metastatic groups. So we still don't know how we are going to address these problems. But it is encouraging to see there is a targeted drug for the Sonic H group. We don't have any specific targets for group 3 and 4. This need further research. Thank you.
Thank you, Dr. Ajit Kumar, for that interesting lecture. Unfortunately, Dr. Ajit Kumar is unable to participate us with this at this moment to take your questions, but you can forward your questions through the online platform. We can forward it to Dr. Ajit Kumar. And we'll be taking a short break before we start in the next session. And I'd like to invite all of our online participants to take part in the teaching capsule and to visit the sponsor launch and the quiz in the virtual platform. And we'll be joining you back at 12 o'clock sharp.
C. Test 1 C. 1 C. Test 1 C. 1 C.
Introducing science-based nutrition for the first time in Sri Lanka. Introducing NutriCan, special nutrition specifically formulated to help prevent severe weight loss, known as cachexia in chronic disease patients such as cancer. NutriCan is enriched with high energy for improved rehabilitation, high protein with BCAA to stimulate muscle repair and strengthen immune function, omega-3 to enhance the chemotherapy efficacy and improve cardiovascular function, high fiber for improved digestion and better nutrition absorption, DHA and EPA to reduce cellular inflammation and improve brain function post-chemotherapy, 11 vitamins, and 10 minerals. NutriCan is strawberry flavored. Kalbi science-based medical nutrition formulations are developed adhering to the highest standard of manufacturing processes and quality assurances. We will continue to give the best to help your life.
Amart Holdings, bringing back happiness in lives. Amart Holdings. Welcome to Amart Holdings Private Limited, one of the leading healthcare service providers in the country. We partner with world-renowned healthcare pharmaceuticals and chemical manufacturers to bring latest technology, products, and services to Sri Lanka. We provide high-end genetic diagnostic services, personalized treatment plans for different types of cancers, best quality pharmaceuticals for affordable prices, and we facilitate foreign medical treatments from well-known hospitals in Singapore, Malaysia, India, and around the world. For further information, visit www.amartholdings.com. Amart Holdings, bringing back happiness in lives.
We're going to start the next symposium. Before starting the symposium, I'd like to give a reminder for our online participants. There's a quiz on our online platform. Quiz A is for medical officers based on the pre-Congress workshop. And Quiz B is radiotherapy related problems, specially designed for the trainees and medical physicists. Quiz B is on chemotherapy for medical officers and trainees. And quiz D is again for radiotherapy related problems and specially designed for the trainees. And in all the quiz, all the categories, those who have performed well will be given a best achievement certificate. And all the other participants in our online platform will receive the e-certificate. And with that, we move on to our next symposium on gynecological oncology. The first lecture on this symposium is on fertility preservation in cancer care. The first lecture would be by Dr. Rajat Vijayasinghe. Dr. Rajat Vijayasinghe is a consultant in gynecological oncology, currently working at Teaching Hospital, Anuradhapura. He graduated from University of Colombo and has won several awards, including the Best Scientific Oral Presentation at the SLCOG International Congress in collaboration with FIGO in 2017. He has gained his experience in gynecological oncology at National Cancer Institute Maharagama, National Hospital Kandy, and Royal Surrey NHS Foundation Trust, UK. He is a co-author in number of publications in peer-reviewed journals and clinical guidelines, and has number of papers published in scientific meetings. I'd like to invite Dr. Rajat Vijayasinghe to the podium and to start the lecture.
Thank you very much for that kind introduction. First, I would like to thank the College of Oncologists for providing me this opportunity. And because of lack of time, I will straight away go into the presentation. Compared to many years ago, situation many years ago, now we see more and more young cancer survivors enjoying almost a normal life expectancy. In that background, it is responsibility of us as clinicians to make sure that the treatment that we provide them would not reduce their quality of life significantly. The ability to reproduce is considered as a part of being a man, a woman, or a human itself. Therefore, during next few minutes, I will be discussing various treatment options available to reduce the fertility loss in cancer care. Loss of fertility in cancer care is not just limited to cancers of reproductive organs. This is because the loss of fertility is mainly due to the treatment that we provide them and not usually due to the cancer itself. So there are several mechanisms. There are several mechanisms for loss of fertility in these patients. With surgery, they can lose reproductive organs or its functions. And with chemotherapy and radiotherapy, the gametogenetic functions of gonads can be lost, as well as with radiotherapy, again, there can be damage to the reproductive organs. Finally, we should not forget that there's a big psychosexual component in reproduction as well, which is often impaired in cancer patients. If we look more details into the possible mechanisms, the standard management of gynecological cancers, there's often hysterectomy and oophorectomy, which would definitely cause fertility impairment. However, even following fertility sparing surgeries in gynecological cancers, because of the post-operative adhesion formation and sometimes cervical stenosis after fertility sparing surgeries in cervical cancers, still they would have problems with fertility. Again, following surgery for non-reproductive pelvic cancers, again, they can suffer from adhesion formation and impairment of tubal functions, which would also cause fertility problems. Going into chemotherapy, the effects of chemotherapy is also not just confined to gynecological cancers. It has been well documented that the cycle non-specific chemotherapeutic agents have more incidence of harm, full effects to ovaries, that is premature ovarian failure, compared to cycle-specific chemotherapy. If we are to look into possible mechanisms, we'll have to recap our physiology knowledge on gametogenesis. And as you may all recall, the ovulation process is controlled by the hypothalamic pituitary ovarian axis by a negative feedback mechanism, where the GnRH that is produced in hypothalamus acts on the anterior pituitary and will cause release of follicular stimulating hormone. The primordial follicles that is in the ovaries would then start growing under stimulation of follicular stimulating hormone, and they would produce anti-Mullerian hormone, which is a negative which would act as a negative feedback mechanism on pituitary and hypothalamus. When the chemotherapy is given, these follicles are destroyed and the production of anti-Mullerian hormone is lost. Because of that, the follicular stimulating hormone will be increased and more primordial follicles will be recruited into the growing pool of follicles. Because of that, there would be more follicles that would be susceptible for chemotherapy. This is called the burnout theory, and this will cause a vicious cycle. When we go to radiotherapy, in addition to loss of gametogenetic functions, there are direct effects on uterus and tubes as well. And when you take radiotherapy to the when you take the cranial radiation, there can be effects on hypothalamic pituitary axis, which would cause infertility. However, this can be easily overcome by artificial application of reproductive hormones. If we are to look into more details about the effects of radiotherapy in the uterus, with the radiotherapy, both myometrium and the endometrium would go into atrophy and fibrosis, and there are changes in the blood vessels as well. In these patients, even if there is even if the ovum is naturally fertilized by a spermatozoa, because a well-primed endometrium is needed for this ovum to get implanted. Most of the time, even though there is a fertilization, they would not get implanted. And by, if any chance, if they get implanted, this uterus is unable to expand to conceive the pregnancy. So they would go into early first trimester miscarriage. Now that we have looked into possible causes of fertility impairment, let's look at how to prevent them. First, we look at how to prevent fertility impairment caused by surgery. If you have to take ovarian cancers, there are two options. One is to go for a fertility sparing surgery. Other method is to go for assisted reproductive techniques. Because assisted reproductive techniques would be option for many, option to preserve fertility in many treatment modalities. I would be discussing that separately. Conservative surgery in ovarian cancer can be offered to early epithelial and sex cord ovarian tumors, as well as germ cell ovarian tumors, which can be quite as well as advanced stage and early germ cell tumors. However, it is often after the surgery that we would definitely know whether it's an early cancer or a epithelial whether it's a germ cell tumor. So we need to be very conservative in managing ovarian cancers in young patients. So there are two approaches. One is to go for a two-stage procedure. In two-stage procedure, what we would do is initial procedure would be, initial surgery would be a diagnostic, and we would only do a minimal, that would be maybe biopsy, ovarian cystectomy or oophorectomy, or sometimes we might do fertility sparing staging laparotomy, including omentectomy, para-aortic lymph node dissection, and taking biopsies from the suspicious site. There's another option of intraoperative frozen section, where intraoperative frozen section analysis would be able to tell us whether this is a benign, borderline, no, malignant tumor with accuracy about 85%. However, out of these two options, the problem is if the patient is not having any child, there's always 15% chance of error in intraoperative frozen section. And the other problem is, even though intraoperative frozen section is good at telling you whether it's a cancer, borderline or benign, we would need a final pathology assessment to know whether it's actually a stage 1A or 1B. So therefore, I usually would like to go for two-stage procedure in patients who do not have any children at all. However, I would use the utility of intraoperative frozen section to decide how much I'm going to do in the initial surgery. So for example, if I have the facilities of an intraoperative frozen section, following oophorectomy, if I can do a frozen section, if it comes as a malignancy, I would be able to do a fertility sparing staging laparotomy, in which case chances of patient going into a second surgery in situation of a stage 1A or 1B disease would be minimal. So therefore, we can reduce the surgical morbidity to this patient. The golden rule in two-stage procedure is we should avoid surgical upstaging in the primary surgery. Going into cervical cancers, again, we have the same two options, fertility sparing surgery and assisted reproductive techniques. Fertility sparing surgery in cervical cancer is only possible up to stage 1B1. And this should be assessed by a preoperative MRI scan, and patient should not have any, the cancer should not involve the body of the uterus. And the distant metastasis should be excluded by CT scan, preferably by a PET CT scan. And the histological assessment, the initial biopsy should be assessed by an experienced pathologist. With the stage 1A1 disease, they can be treated with the cone excision with at least a 3 millimeter margin. Stage 1A2, that is lesions between 3 to 5 millimeters, or stage 1A1, that is lesion with less than 3 millimeter, with lymphovascular invasion, they should be treated with cone excision as well as a pelvic lymph node assessment, because they have about 5% risk of lymph node metastasis. Stage 1B1 should be treated with the abdominal or vaginal trachelectomy with bilateral pelvic lymphadenectomy. Few words about trachelectomy. In trachelectomy, what we do is there is a radical excision of the cervix with the adequate parametrial margins as well as vaginal cuff. Then the rest of the uterus, that is the uterine body, would be re-anastomosed to the vagina, and there would be a purse string suture around the internal os of the uterus to make sure that the uterus is able to keep a pregnancy. When we take endometrial cancers, we do not do conservative surgery per se. What we would do is a medical management of endometrial cancer. Then patient is allowed to try for fertility, and following that, patient will have a completion surgery. Again, we can use assisted reproductive techniques in endometrial cancers, but its uses are limited because endometrial cancer is an estrogen driven cancer, and assisted reproductive techniques are associated with high levels of estrogen, and there are theoretical risk of disease advancement. However, it is not completely impossible, and there have been cases done with assisted reproductive techniques. In managing endometrial cancers medically, there are some very strict criteria. They should be a grade 1 endometrial cancer, and the histology should be by DNC and not by people, because the sample, the amount of sample that is retrieved from a people biopsy is quite low. There's a chance that we can miss a high-grade disease. A high-grade disease might be downgraded in a people biopsy. Therefore, it is always recommended that endometrial cancer diagnosed by a people biopsy as stage 1, grade 1, who is been considered for conservative treatment, to have a re-biopsy by a dilatation and curettage. And they should undergo MRI scan, and there should not be any myometric invasion, and there should not be any distant metastasis. And always these patients should be referred to a reproductive medical specialist to discuss regarding options, because these patients should be referred to assisted reproductive techniques once the malignancy is treated medically. The medical treatment is quite standard. Very high dose of methoxyprogesterone acetate, 400 to 600 milligrams is given daily. However, now there's increasing use of levonorgestrel release in intrauterine device because of the high side effect profile of systemic progesterones. And these patients are, endometrial biopsies are done every 3 monthly. And once we get one negative sample, one endometrial biopsy sample, then these patients are usually referred for in vitro fertilization. And the success rates are around 25% to 30%. Let's talk about how to prevent fertility loss due to pelvic radiotherapy. The options are, again, there's an option of ovarian transposition and assisted reproductive techniques. Ovarian transposition is a method to transfer the ovary from the normal anatomical site to a site away from the radiotherapy, usually at least at the level of iliac crest. And then, if possible, we can place the ovary more higher up in the paracolic gutters. The importance of this method is it will preserve both endocrine and reproductive functions. So if you use assisted reproductive techniques, they would only preserve reproductive functions. Because the ovary is kept within the body, they will continue to produce hormones, and the success rate is between 70 to 90%. This is a picture of ovarian transposition. And ovarian transposition can be done with or without tubal excision. And if the tubal excision is done, they will definitely need assisted reproductive techniques to conceive. However, if the tube is kept in situ, there's a possibility of spontaneous conceivement as well. Then lastly, fertility loss due to chemotherapy. One of the emerging options are GnRH analog co-treatment. There has been observations that premature ovarian failure among pre-pubertal girls who are receiving chemotherapy is less than those who would receive less than post-pubertal girls or women who receive chemotherapy. And the possible mechanisms is the reversal of burnout theory I spoke earlier. And there are other possible explanations such as direct effects of GnRH on follicles, protecting them against chemotherapy, decrease in the ovarian perfusion, and protecting possible stem cells in the ovaries that can later convert to oogonia and primary oocytes. So currently there's mixed evidence on GnRH analogs, but there has been a lot of meta-analysis that has shown improved return of ovarian function as well as pregnancy in breast cancer in those who have received GnRH analogs. Currently, they are under limited use. Going into assisted reproductive techniques, this can be used to prevent fertility loss in surgery, chemotherapy, as well as radiotherapy. The options for males are semen cryopreservation, and this can only be done in post-pubertal boys or men. However, at the moment, there's no viable option for pre-pubertal boys, but testicular tissue freezing is under research at the moment. There are many options for females for fertility preservation. The best would be embryo cryopreservation, and this would be offered only to a post-pubertal female with a stable partner. And this process would involve ovarian stimulation with a follicular stimulating hormone for at least 2 weeks. And then the follicles, the ovum would be retrieved through a vaginal probe. And they would undergo artificial insemination and rapid freezing. However, in the post-pubertal women or girls without a partner, there's an option of ovum cryopreservation. So these patients would undergo the same procedure as in embryo cryopreservation. However, there's no insemination. The ovum would be freezed. However, the problem in this is the stability of frozen ovums are less than the stability of frozen embryos. This is because the ovum, this is a secondary oocyte which has been arrested at the second metaphase. So it's quite unstable. So always, if there's a stable partner, it is always advisable for them to undergo embryo cryopreservation. Luckily, for females, the pre-pubertal girls have a now option of ovarian tissue cryopreservation. In this procedure, parts of ovarian tissues are retrieved, usually by laparoscope, and these ovarian tissues are then preserved. Later on, they have frozen, and later on, these ovarian tissues can be re-implanted to the ovary itself, or sometimes they can be implanted to pelvic peritoneum nearby the ovary, which should again function as a functioning ovary with both endocrine and reproductive functions. And sometimes they can be implanted in ectopic sites, maybe anterior abdominal wall, upper arm, where you will have to use artificial reproductive techniques to harvest the eggs and then try for fertility. So this reproductive technology is not without risks. They can delay in treatment initiation. However, the delay is usually 2 to 3 weeks. They have its own complications, such as ovarian hyperstimulation syndrome, or the surgical processes that is used to retrieve specimen which can also be associated with risks. And there can be effects of high estrogen levels, especially in cancers which are sensitive to estrogen, the breast cancers and endometrial cancers. Therefore, currently, the protocols would include adding letrozole, which is an aromatase inhibitor, to minimize these risks. Finally, in conclusion, follicle preservation should be considered in every cancer patient who has a potential to reproduce. However, this should not hinder individuals' probability to have the best life-saving treatment. A multidisciplinary approach involving the clinical oncologist, gynecological oncologist, as well as a fertility medicine specialist is recommended for best possible care for these patients. With that, I would be concluding my presentation. Thank you. I would like to take any questions.
Thank you very much, Dr. Vijay Singha, for that very informative presentation. I would like to invite you to the head table, and we will give the audience a chance for questions at the end of the whole symposium.
Thank you.
Our next speaker for this symposium is Mr. Raj Naik. Mr. Naik is a consultant gynecological oncologist, previously clinical director at the Northern Gynecological Oncology Center and former president of the British Gynecological Cancer Society. He is the editor in the British Journal of Obstetrics and Gynecology, member of editorial board for gynecological oncology with over 100 publications, reviews, chapters, and is the co-author of the 10th and 11th edition of Bonnie's Gynecological Surgery. His current research and clinical interests are ultraradical surgery for advanced ovarian cancer, extentative surgery for recurrent disease, and sentinel node biopsy for early stage gynecological cancers. He will be talking on recent advances in the surgical management of ovarian cancer. Over to you, Mr. Naik.
Okay, hello everyone. My name's Raj Naik. I'd like to thank all of you for inviting me at this prestigious conference. Of course, it's very sad that I cannot be there in person, but I'm absolutely delighted to have prepared this talk for you. I hope you find it useful. The title of the talk is Updates in the Surgical Management of Ovarian Cancers. So the content of my presentation will include stage 1 disease. I'm going to talk about frozen section analysis and the value of staging, but also, if need be, carrying out a second operation to complete the staging procedure. I'll also talk about staging and the need for fertility preservation in young women, and also some of the recent work that's been carried out on sentinel node assessment for early stage disease. I'll then focus mainly on advanced disease and discuss the ongoing things of chemotherapy, but also the important objective, which is to achieve complete site reduction. And I'll cover briefly a recent randomized controlled trial from Germany called the LIONS trial on systematic pelvic paraaortic lymphadenectomy. I'll also very briefly cover HIPEC, which is heated intraperitoneal chemotherapy for primary surgical treatment, but also for recurrent disease, and briefly VATS, which is video-assisted thoracic surgery for stage 4 disease, and some of the recent publications on surgery for recurrent disease, which includes the desktop study and the SOC1 study. I'll conclude by making my recommendations for ESCO accreditation and also the recent publications on quality indicators for surgical treatment, but also perioperative management for advanced ovarian cancers. So starting with frozen section analysis and complete staging, well, all the recent work on this still emanates from the original publication from the EORTC, which is almost 20 years old now. It's the ACTION trial, and it compared optimal staging with suboptimal staging or no staging at all. And you can see from this slide that the best survival was achieved in those patients that were optimally staged. And that included performing an omentectomy, peritoneal washings, random peritoneal biopsies, but also sampling of the pelvic and parotid lymph nodes. We'll see from there analysis slides with overall survival on the left and recurrent-free survival on the right, that the best outcomes were achieved with optimal staging without the need for chemotherapy. But for those patients in whom chemotherapy was given, one could improve the survival outcome to those patients that were optimally staged but did not receive chemotherapy. Choices really from this study are either carry out optimal staging or don't carry out optimal staging and instead give all patients chemotherapy. So they're the choices. So it's on the basis of that people became more interested in intraoperative frozen section analysis, so that a histological diagnosis could be made at the time of the initial surgery, and from there then carry out a full staging procedure as based on the ACTION trial. We introduced it shortly after the ACTION publications, and this was our initial experience, which was published in the IJGC. We then published our much larger series of over 2,000 patients in the British Journal of Obs and Gynae, and more recently we've carried out a Cochrane review where we've reviewed all of the published literature and shown excellent diagnostic benefit in carrying out intraoperative frozen section analysis. So in carrying out intraoperative frozen section analysis, one can then obtain a histological diagnosis and be selective in which patients then undergo a full and complete staging procedure at the time of the initial laparotomy, and from there avoid giving chemotherapy to a good majority of stage 1 patients. Now, clearly that involves carrying out a pelvic and parotid lymphadenectomy, and in the absence of a classification system for parotid node dissection, we therefore devised one which we published in the British Journal of Obs and Gynae, and we defined what a systematic parotid lymphadenectomy should entail. And here's a photographic illustration of one here, showing removal of all lymph nodes and fatty tissues around the major vessels, up to and slightly above the renal vessels. So if you don't have access to frozen section analysis, the option still is to carry out a second surgical procedure and carry out a staging procedure at that second operation. This is a Cochrane review from Falsetta et al. Comparing laparoscopic versus laparotomy for the restaging procedure. And so there are many publications on this topic. They found no randomized controlled trials in order to compare the two strategies. And the conclusion from this really is that one can either carry out a laparoscopic second procedure for restaging or carry out a second laparotomy. This is a publication from a year ago from Liu et al. Looking at fertility preservation, and in young patients who present with unilateral pelvic masses which are confirmed to be ovarian cancer. The question really is, can you retain the contralateral ovary and uterus and therefore preserve fertility? And does this have a detriment to outcome survival? And they've reviewed all of the literature and carried out a meta-analysis, And on the basis of the currently available observational studies, there appear to be no difference in overall survival and disease-free survival using either surgical technique. So really, from this publication, it would seem appropriate to preserve the contralateral ovary and uterus, still carry out a staging procedure in terms of peritoneal washings, peritoneal biopsies, omentectomy, pelvic paraortic node sampling, but still preserve fertility with no detriment to outcome survival. There's been more people currently showing interest in sentinel node assessment. I think you'll all be familiar with the benefits of sentinel node assessment for vulval cancer, cervical cancer, and endometrial cancer. So what I'm going to do now is show you a video of the potential benefits of sentinel node assessment in early-stage ovarian cancer. This video shows a quite large left ovarian mass. The retroperitoneum has been dissected, and you can see here the left IP ligament with the psoas muscle and the pelvic mass. And what we're going to do now is inject ICG at the base of the IP ligament, which we'll illustrate here. And then using a special SPY-FI camera, which emits infrared, we'll be able to visualize the passage of the injected ICG through the lymphatics alongside the IP ligament. So by use of infrared light, the ICG is showing as a luminous green. And as you can see, the dye is now traveling through the lymphatic channels across the IP ligament and up towards the paraortic area, in fact, not the pelvic area. You can see the ureter coming into view here, and the channel is continuing to travel up towards the paraortic nodes. And there's the sentinel lymph node there, just lying infrarenal alongside the paraortic area. So the benefit of this is that one can simply remove that sentinel lymph node without carrying out a full pelvic or paraortic lymph node dissection, thereby reducing morbidity as well as surgical complications, stroke morbidity. So that's early stage disease. Moving on to advanced stage disease, I'm going to start really with these two main publications. They're quite old now, over 10 years old. On the left is the Lancet publication on the CHORUS trial on neoadjuvant chemotherapy, which is predominantly a UK study. On the right is the EORTC study, in other words, mainly European, published in the New England Journal of Medicine. And both showed the same conclusions, which were that treatment, whether it be by primary cytoreduction followed by 6 cycles of chemotherapy, or whether one treated with neoadjuvant chemotherapy, in other words, 3 to 4 cycles of chemo followed by surgery, and then completion chemotherapy, the outcome survival was much the same, whether it be overall survival or recurrent-free survival. Now, this caused a huge amount of debate, especially in America, but on the basis of these two publications, certainly neoadjuvant chemotherapy has increased in popularity, especially in light of the fact that the surgical cytoreduction appears to that's needed, becomes less radical, and as a result, there's less morbidity for the patient. The study was performed again. This is by the Italian group called the Scorpion study. It was published a year ago in the IJGC, and it's from my good colleagues in Rome, Anna Vigotti and Giovanni Scambia, and they showed similar results to the CHORUS trial and the EORTC trial, which is that whether it's primary debulking surgery or neoadjuvant chemotherapy, the survival outcome is superimposable. However, there was less toxicity with neoadjuvant chemotherapy, and as with the previous publications, residual tumor is the main prognostic factor to any surgery, whether it be primary surgery or interval surgery. So really, even the more recent publications are confirming what the previous publications had shown, which is that neoadjuvant chemotherapy is certainly an option, especially in women who have serious comorbidities or disease that's extremely extensive, where primary surgery would become very difficult. However, all studies have still emphasized the importance of achieving complete site reduction. So in terms of recent advances, I think what we're seeing is that more and more centers are becoming more and more radical with their surgery in order to achieve complete site reduction. This is a Cochrane review that we performed some years ago, which in fact we're just about to update again. And the results from our recent update, which are not yet published, are equivalent to what we showed previously, which is that the best outcome survival is achieved, is seen in women where we've achieved complete reduction. So this was our previous forest plot, and our more recent one, which is still to be published, is very similar, and it shows a massive improvement to outcome survival in patients where there is zero residual disease, and it showed a hazard ratio of 3.16. We carried out a further Cochrane review on whether ultra-radical surgery was needed to achieve complete site reduction, and the results were much the same as what I've just shown you, which is that the best results are, whether ultra-radical surgery is required or not, the best outcome survival is in those patients where complete site reduction is achieved. As a result of this, our current NICE recommendations in the UK is still the same, where the recommendation is complete resection of all macroscopic disease in our attempt to achieve complete site reduction. And again, these remain the national and international recommendations, whether it be ESCO, SGO, or the Australasian guidelines. So this is the kind of surgery that often involves the surgery in the upper abdomen, around the liver, or the spleen, or the diaphragm. Quite often extensive bowel surgery is required, and you know, even including total colectomies, splenectomies. This is a recent operation that I carried out, just showing the extent of surgery that's sometimes necessary. She's had a complete pelvic paraortic peritonectomy with an en-bloc TAH, BSO, total colectomy, splenectomy, omentectomy, and endoilectomy. And that's the uterus and cervix attached to the rectum, colon, all removed as an en-bloc procedure with extensive peritonectomy. I've got this video here as well, just to illustrate that disease involving the small bowel or small bowel mesentery in itself is not a contraindication to achieving complete site reduction. One can perform a mesenteric stripping procedure and still preserve vascularity. So you can see there's lots of miliary disease involved in the small bowel mesentery, and with it being mostly superficial, it is possible to strip that mesenteric peritoneum and still achieve a site reductive outcome. This lady had already received neoadjuvant chemotherapy, so we're performing this as a interval debulking procedure, which is why there's also some chemotherapy scarring. But again, that in itself does not prevent achieving a good surgical outcome. So you can see we're stripping the small bowel mesentery with the overlying tumor. We've done that for the whole of the dorsal and ventral mesentery. And you can see here all of that mesenteric tumor has been removed with the peritoneum. We can also excise superficial tumor deposits on the small bowel. As part of our cytoreductive procedure, as you can see, I use argon beam coagulator. I also use plasma jet as a form of excising or thermally ablating tumor. I then use ICG, injected intravenously, to assess bowel vascularity to ensure that the mesenteric stripping didn't damage any of the vessels that's feeding into the small bowel. So you can see that the whole vascularity has been preserved despite a very extensive mesenteric peritonectomy. This next video shows disease involving the pelvis, predominantly the pouch of Douglas, rectum, sigmoid mesentery. She's already had a pelvic peritonectomy, and what I'm now going to do is strip the peritoneum off the front of the rectum and also the sigmoid and sigmoid mesentery, and avoid having to do a rectosigmoid colectomy. In other words, there are different means and methods of achieving complete site reduction without necessarily carrying out a bowel resection. So we're stripping the peritoneum off the anterior surface of the rectum here. What you can see is disease there in the pouch of Douglas, also the rectum, but also the surrounding peritoneum. And we're going to continue the dissection of that peritoneum cranially up the rectum and sigmoid, and from there we'll also remove the sigmoid mesenteric peritoneum. So all of the tumour there involved in the rectum and sigmoid and mesentery has been removed. So we've achieved complete site reduction without having to resort to a rectosigmoid colectomy or stoma. I'm now injecting ICG as with my previous video. Again, this is confirming that the vascularity to the rectum and sigmoid is intact, despite the extensive peritoneal stripping. So again, the next few slides really is to show that, you know, as well as bowel surgery, one can perform ureteric procedures. Quite often, pelvic masses will cause hydroureters, and with the extensive dissections, the ureters can be compromised. If you don't have access to a urologist, and if you don't do cystoscopic stent insertions, a simple method is to carry a transureteral stent insertion using a pigtail stent, making a small cut ureter, inserting the stent, and closing it transversely. And this lady, in fact, had both her ureters stented and you can see that this helps with reduction in the post-operative fistula rate formation. I want to talk briefly about the Lions trial. This study is from the Germans and AGO group, and it showed that when in advanced disease, when you've achieved complete abdominal cytoreduction, there is no value in carrying out a pelvic para-aortic lymphadenectomy when there's no clear evidence that the lymph nodes are involved. In other words, when they're normal based on size criteria, there is no survival benefit in doing a systematic pelvic or para-aortic lymphadenectomy. And all it does is increase the risk of post-operative complications. Moving on to HIPEC, this is a randomized controlled trial that was published in the New England Journal of Medicine. It's from the Dutch group, and it showed that there was survival benefit in treating with heated intraperitoneal chemotherapy, where for primary disease when carried out as an interval debulking procedure, in other words, after neoadjuvant chemotherapy. This study is being repeated as a much larger study, so it'll be interesting to see whether these results are replicated. This is a US study that was also published earlier this year. It's looking at the value of HIPEC in recurrent disease, and in fact they got a negative result. They showed no evidence of survival benefit in recurrent disease using carboplatin as the agent for intraperitoneal chemotherapy. In terms of video-assisted thoracic surgery, this is really quite a new strategy where people are trying to determine stage 4 disease and as a result change their surgical strategy based around that. This is a meta-analysis that was recently published showing that in up to 40% of cases, carrying out VATS does change the surgical decision or stage. I'm not going to show you the full video, but you can see this is a VATS procedure showing the lung parenchyma, pleural effusion, and also the pleural disease. This is on the pleural side of the diaphragm, showing quite extensive tumor deposits. In terms of recurrent disease, this again is a German study. It's the desktop study, and it's not published fully as yet, but the final analysis has been published in abstract form, and what it shows is that there is significant survival benefit in carrying out surgery for patients who have recurrent disease, where they have a positive AGO score and a greater than 6-month treatment-free interval. And this result was replicated by the Chinese study in the SOC1 study. Both of these studies are randomized controlled trials, and both have shown a survival benefit in carrying out a cytoreductive procedure prior to chemotherapy in patients with recurrent disease when there's been greater than 6-month treatment-free interval. This is a Cochrane review that we carried out previously on surgery for recurrent disease, which clearly now is in need of updating on the basis of these two randomized controlled trials that have recently been published. I think in terms of all of what I presented, what I really want to recommend is that it's all done as part of a team. There have to be quality indicators in surgery for advanced ovarian cancer. And there has to be recommendations or quality indicators for the perioperative management. This is all published in 2 recent publications from ESGO, which is the European Society of Gynecologists. So I highly recommend reading these 2 publications if one is carrying out the kind of surgery I've just presented for advanced disease. I'd like to conclude by simply saying that for early stage disease, frozen section analysis remains the gold standard. People are showing more interest now in sentinel node assessment. Fertility sparing surgery appears to be viable with comparable survival outcomes. For advanced disease, complete site reduction is still the primary objective. However, this has resulted in increased radicality with surgery involving upper abdomen, bowel surgeries, as well as intrathoracic surgery. Neoadjuvant chemotherapy is becoming more acceptable, and there's no indication for lymphadenectomy unless there's clear involvement with tumour. For recurrent disease, there's 2 recent randomized controlled trials showing better outcomes with surgery plus chemo rather than chemo alone. HIPEC may be advantageous in primary disease as an interval debulking procedure, but further studies are ongoing. VATS is still really investigational, and I think we need to see more publications on this before recommending it as standard treatment. And as with all radical surgery, it's all about quality indicators. Thank you very much. I'd like to thank all of you for inviting me at this prestigious conference. Of course, it's very sad that I cannot be there in person, but I'm absolutely delighted to have prepared this talk for you. I hope you find it useful. The title of the talk is Updates in the Surgical Management of Ovarian Cancers. So the content of my presentation.
Thank you, Dr. Naik, for that. It was an interesting lecture for both our surgical and oncology colleagues. I hope we'll be able to answer a few questions at the end of the symposium. And if we move on to the next lecture, and it's an honor for me to introduce Professor Linda Mileshkin. Professor Mileshkin is a medical oncologist and a researcher with a particular interest in the treatment of gynecological cancers, as well as supportive care of people affected by cancer. She also runs Australia's only specialist clinic dedicated to the care of people affected by cancer of unknown primary. She is the interim director of medical oncology at Peter MacCallum Cancer Centre and the clinical trial lead for gynae oncology in Parkville Cancer Clinical Trial Unit. She is also very much involved in the Australia and New Zealand Gynecological Oncology Group as a member of the board and the research advisory committee. And she'll be talking to you on medical management of stage 3 ovarian cancers. Over to you, Professor Mileshkin.
Hello. Thank you for the opportunity to talk to you today about the medical management of stage 3 ovarian cancer. My name is Linda Mileshkin, and I'm a medical oncologist from the Peter MacCallum Cancer Centre that you can see pictured here in Melbourne, Australia. So I'm going to talk to you a bit about what's new in adjuvant therapy in terms of increased use of neoadjuvant chemotherapy, routine BRCA testing, as well as the use of PARP inhibitors as maintenance therapy. So it is important to recognise that epithelial ovarian cancer can be of different histological types, as you can see pictured here. But really the most common one that we see is high-grade serous ovarian cancer that accounts for about 3/4 of the cases, and this is the predominant cell type that we manage in the clinic. FIGO staging is the main way that we stage patients, and stage 3 disease refers to those patients that present with more advanced disease, with this being spread to the rest of the peritoneal cavity outside of the pelvis, often involving the omentum, as well as sometimes positive lymph nodes. And these patients have historically quite poor survival outcomes at 5 years, as you can see listed here. So standard treatment for ovarian cancer usually involves a combination of surgery and chemotherapy. And the surgery would traditionally involve a staging laparotomy as well as total abdominal hysterectomy, bilateral salpingo-oophorectomy, as well as debulking surgery, including omentectomy. And platinum and taxane chemotherapy is our standard backbone. Obviously, for non-epithelial tumours, which often occur in younger women, these can sometimes be very chemosensitive germ cell tumours. Sometimes these women can be managed with fertility-sparing surgery and be treated with germ cell chemotherapy with extremely good outcomes. In terms of the surgical approach, the aim is to get resection of all macroscopic visible disease or minimise the amount of residual disease. It's thought important to debulk any obviously bulky lymph nodes, as these may be relatively chemo-resistant. And really, survival is proportional to the amount of residual disease left at the end of the operation. And for those patients with no macroscopic disease, these are the ones that we have the best outcomes with survival times, hopefully more than 5 years, compared to much shorter in those that had larger volume residual disease. The debulking surgery can be quite intense, particularly if the aim is no macroscopic residual disease. It's not infrequent to require that the gynecological oncologist needs help from other surgeons, such as hepatobiliary surgeons, colorectal surgeons, or occasionally chest surgeons. And in patients that have this type of extensive surgery, we need access to the ICU, and as well as patients who are fit enough to undergo such extensive surgery. And even in the best hands, mortality rates of up to 5% can be reported. In terms of adjuvant therapy, these are the recommendations from our Cancer Australia guidelines, which is similar to guidelines elsewhere in the world. So generally, adjuvant chemotherapy is not recommended in tumours of low malignant potential, such as borderline tumours, unless there are invasive peritoneal implants found histologically. Whereas adjuvant chemotherapy is recommended for early stage patients if there's a high grade or clear cell component, as these patients may have a high recurrence rate. Whereas it's not recommended for early stage cancers that have had comprehensively staged 1A or 1B disease that's well or moderately differentiated. For our stage 2B or greater tumours, standard treatment recommendations are to have first-line platinum and paclitaxel chemotherapy. So recently there has been interest in whether we can do better than 3-weekly carboplatin and paclitaxel, and this particularly came about because of this study out of Japan that compared the use of 3-weekly carboplatin paclitaxel with the same carboplatin but paclitaxel given in a dose-dense or weekly fashion, based on data suggesting that this is better in breast cancer. And it did seem that the weekly treatment did better, and many units changed practice as a result of these findings. However, subsequently we've had the results of the ICON-8 trial, which randomised women into 3 different arms, 3 weekly of both drugs, 3 weekly carboplatin with weekly paclitaxel, similar to the Japanese study, or weekly use of both drugs. And this trial also allowed the option of interval debulking surgery. In this trial, different from the Japanese study with the ICON-8 mostly done in a Caucasian population, in fact, toxicity was increased, if anything, in those patients who received the weekly treatment. And perhaps this was because of the dose intensity of the paclitaxel that was given. Also, the trial proved to be negative. You can see here the overlapping curves, progression-free survival, as well as overall survival, as well as progression-free survival broken down by interval or primary debulking. Really no difference between the arms, and so 3 weekly carboplatin paclitaxel remains our standard chemotherapy backbone. However, we are increasingly using neoadjuvant chemotherapy, and this is as a result of 2 trials that you can see listed here. one led by Ignace Fagote with the EORTC and the other Chorus study run out of the UK, which compared the use of primary debulking surgery followed by 6 cycles of chemotherapy to starting with 3 cycles of neoadjuvant chemotherapy, then having interval debulking surgery and completing the rest of the chemotherapy. And as you can see here, really the median progression-free survival, although lower than in some of the other trials, was really the same in both of these trials, as was the median overall survival. Another important finding was that there also appeared to be lower post-operative mortality rates, as well as a low risk of complications with the neoadjuvant approach. And hence it's really become quite common practice, particularly for those patients who are, very unwell at presentation, who might not manage to get through an operation well. Always this concern about the ability to achieve optimal debulking, that we now start with neoadjuvant chemotherapy. But this decision needs to be made in a multidisciplinary meeting with discussion between the medical oncologists and the gynecological oncologists. The other thing that's changed is really recognition of the great importance of BRCA mutations in this disease. So we now know that of the 3/4 of patients that have high-grade serous carcinoma, that about 15 to 20% will carry a germline BRCA mutation. And that's often regardless of whether or not the woman describes any family history of cancer. In fact, about 50% of these cancers do have some type of defect in homologous recombination, whether it be a germline finding or a somatic BRCA mutation or other types of defects in the pathway, such as methylation of BRCA or mutations in other parts of the pathway. And hence it's now recommended that really all women diagnosed with a high-grade ovarian cancer at any age should undergo testing, genetic testing for BRCA1 and BRCA2 mutations. And this is different from the recommendations for breast cancer. And this is also the case for the ASCO guidelines, and these are worth having a read of because they do really describe that they recommend initial testing be done by germline panel testing rather than starting with a somatic BRCA test, which is commonly done and often something that's recommended by the makers of PARP inhibitors. But really the advantage of starting with germline testing is that you're less likely to miss germline findings this way. It's also recommended that women with clear cell endometrioid or mucinous ovarian cancer should be offered somatic testing for mismatch repair deficiency because some of these women may carry Lynch syndrome. And the reason that they recommend starting with germline testing is it's thought that if you only do somatic testing, that you may miss up to 5% of women with a germline mutation, which obviously could have important implications for the family, who may be falsely reassured that they're not at risk of developing tumours. And the way that we now do this in practice is by so-called mainstream genetic testing. So where the oncologist actually orders the test rather than sending the patient to a genetics or family cancer clinic to get the testing done. And the advantage of this is that we can do it when we first meet the woman by getting her to have a blood test, and we can get the results back more quickly because of the potential for impact on the care of the woman herself. We do have various information sheets such as this brochure that we're able to give women to help them understand the complicated information about BRCA testing at a time when they're already pretty overwhelmed after hearing that they indeed have cancer. And then what we do is refer for genetics follow-up in the familial cancer clinic for those women found to have a germline BRCA mutation or indeed an unclassified variant of VUS, so that the clinic can then discuss the result and the implications for the woman herself as well as for her other family members, and arrange for cascade testing of other interested family, as well as offer psychological support and follow-up of families. So this also reduces the burden on the familial cancer clinic of not having to see all of our patients. So PARP inhibitors, they're really the first treatments for a subset of patients who have an inherited basis for their cancer. So in a person who carries a BRCA mutation in a normal tissue cell, there will still be one functioning copy of BRCA. And because of this, BRCA function is retained and there will be normal DNA repair. However, in tumour cells, generally the cause of the ovarian cancer is developing a second abnormality, such that there's no normal functioning BRCA. And those cells have abnormal ability to repair DNA, or so-called homologous recombination deficiency. And the PARP inhibitors exploit this by inhibiting PARP, which is part of the base excision repair pathway, which is a type of way that cells try to repair single-strand DNA damage. And this is a mechanism that cells rely on if they have HR deficiency. And so the advantage of this is that hopefully normal cells are fairly spared of the effects of these drugs, but HR deficient tumour cells, which are BRCA deficient, will hopefully undergo synthetic lethality and die as a result of this treatment. So following the success of PARP inhibitors in the treatment of relapsed disease, they've been brought into the first line setting. And SOLO-1 was a randomised phase 3 trial that took women who had newly diagnosed stage 3 to 4 high-grade serous or endometrioid ovarian cancer with either a germline or a somatic BRCA mutation, who were in complete or partial response following adjuvant chemotherapy, and randomised them to receive placebo or olaparib tablets at a dose of 300 milligrams twice daily for a period of 2 years if there was no evidence of disease. And the primary endpoint of the trial was investigator-assessed progression-free survival. And the trial proved to be highly positive, as you can see here, the big suppression in the curves between olaparib and placebo. And on the right, you can see the percentage of patients that remained free of progression or death at different years following enrolment. So, for example, at the 36-month time point, we had 60% of women in the olaparib arm who were progression-free, compared to 26.9% in those who received placebo, something that we've really never seen before in ovarian cancer. And recently, Susanna Banerjee has published in Lancet Oncology the 5-year follow-up results of this trial, which have shown a very impressive median progression-free survival of 4.5 years in those patients who received the olaparib, compared to just over a year in those receiving placebo. So the PARP inhibitors do come with some toxicity, so they can cause problems with particularly nausea, as well as fatigue, as well as myelosuppression. But generally this is of relatively low grade and something that can be manageable. It's most pronounced in the first month of treatment and often abates over time if you can get women through those first 3 weeks with the use of supportive therapies or dose reduction and dose interruption if required. Another important trial is the PRIMA trial. So this was a slightly different trial in that it really took all comers, not just those with a BRCA mutation, who again were in complete or partial response after 6 to 9 cycles of first-line chemotherapy and surgery, and randomised women to have placebo or 3 years of treatment with niraparib at a dose of 300 milligrams daily. The primary endpoint was also progression-free survival, and the dosing strategy was amended partway through the trial because niraparib causes more myelotoxicity than other PARP inhibitors, so that lower body weight women, less than 77 kilos, or those with low platelets are recommended to start with a dose of 200 milligrams per day. And this trial did include a group with poorer prognosis than SOLO 1. So you can see here in the baseline characteristics slide that 85% of women did have residual disease after primary debulking surgery. A third of the patients had stage 4 disease, and about a third of the patients had only had a partial response to their first-line chemotherapy. And an important stratification factor was testing for the presence of HRD, and this was done using the Myriad My Choice assay, which tests for both a somatic BRCA mutation as well as presence of a genomic instability score, as you can see outlined here. So tumours are maybe considered to be HRD either based on the presence of a somatic BRCA mutation or a genomic instability score of 42 or more. This was also a positive trial, as you can see here, the clear separation between the curves, with niraparib resulting in a 57% reduction in risk of relapse or death compared to placebo. And you can see in the pie chart below the breakdown of about a third of the patients having BRCA mutation, 20% having HRD for other reasons, and a third of the patients having HR proficient tumours with an unknown group. As I mentioned, this PARP inhibitor does cause more myelosuppression, and you can see here that 70.5% of patients in niraparib did have subtype of grade 3 or greater treatment-related adverse events, and it was not uncommon to have dose reductions or dose interruptions with the use of niraparib, particularly due to thrombocytopenia as well as anemia. But as oncologists, we've had to learn to manage this new class of drugs, and we've got better at doing that over time so that mostly we can make it manageable for the majority of patients. Another interesting thing about PRIMA was really the differential result based on the HRD result. So you can see here the clear difference in the curves in those patients on the left that had BRCA mutations and those that in the middle that were BRCA wild type but still had HRD tumours. Whereas for those, the group on the right that had HR proficient tumours, there really wasn't a big difference. Although it was a statistically significant difference, there was only really a couple of months difference and arguably not really a clinically significant difference in those patients who had HR proficient tumours. Another important trial has been PAOLA-1, which actually was first presented before PRIMA, and this compared the use of maintenance bevacizumab following surgery and first-line chemotherapy incorporating at least 3 cycles of bevacizumab to the same maintenance bevacizumab treatment with the use of olaparib maintenance therapy, again for stage 3 to 4 patients. And in the trial, they also used the Myriad My Choice assay as part of stratification, and you'll see that about half of the patients had HRD positive tumours. This was also a positive trial and showed very similar pattern to what we see in PRIMA, in that there was a clear difference or benefit from the addition of olaparib in those tumours that were HRD positive, whether because of a somatic BRCA mutation or otherwise, whereas really there was no difference at all in the median PFS in those tumours that were HRD negative, which again questions the value of PARP inhibitors in this group. The downside of this trial is that we had no olaparib only arm. So really just to sum up, this is the guidelines recently published by ASCO in 2020 for the use of PARP inhibitors in ovarian cancer. So basically they're not recommended for stage 1 to 2 epithelial ovarian cancer at this point because of a lack of evidence. For those women with newly diagnosed stage 3 to 4 tumours in complete or partial response after chemotherapy, maintenance PARP inhibitors should be offered, which could be olaparib for those with germline or somatic BRCA mutations, or niraparib in the all-comer group. There's a difference in the duration of therapy depending on which PARP inhibitor is available to you. And they also give a further recommendation that olaparib plus bevacizumab maintenance could be offered to patients who have stage 3 to 4 disease, who have evidence of HRD and also have had a complete or partial response to the use of chemotherapy plus bevacizumab. So thank you for your attention. I hope this talk has helped you to further understand the changing landscape of the medical management of stage 3 ovarian cancer.
Thank you very much, Professor Mleshkin, for that comprehensive presentation. We have Professor Mleshkin and Mr. Naik joining us virtually, along with Dr. Vijay Singha here in person, and the symposium is open for questions now.
Thank you for the interesting presentation. And this is for Rajitha. Thank you to discuss the difficult issues in the fertility field. Just my first question is, what's the success rate of using the preserved ovum or sperm in our country? And second question is, whether Sri Lankan law allow the usage of preserved ovum or sperm in IVF in a surrogate mother if the cancer patient dies on request of the family or the patient himself or herself?
First of all, I think this is beyond my scope because it is usually done by a fertility medicine specialist. But what I can say is the success rates usually in IVF from the preserved ovary and spermatozoa, that ovum, usually it is around, I would say, 25 to 30% for a cycle of induction. However, I am sorry that I would not be able to give you the Sri Lankan data. This is the global figure. And with regard to other question, at the moment in Sri Lanka, there's no legal framework for these advanced reproductive methods, and to my awareness, there's a ethical framework for that. Currently, to my knowledge, there's no law governing the surrogacy in Sri Lanka, but I think this would be able to be, this question would be could be answered better by a fertility medicine specialist rather than myself.
Thank you.
But after death of the mother, using the ovum is unethical, I think, no, because her consent is not there unless she has already given a consent.
Yes, of course. Yeah. Then there should be a previous directive in that situation. If that is the situation, there should be a previous directive by the mother, not the mother, the woman who has donated the ovum in that situation. Yes.
And we come across some these breast cancer patients, those who are not having children, and after treatment they ask for pregnancy. Then we send after 2 years, most of the time after 2 years of tamoxifen treatment if they are low risk. Like what is have you come across here in Sri Lanka referred before 2 years, or what is the success rate? And
again, I think that should be gone by the 2 years is a very standard duration, because we need to make sure that she would not get a recurrence, and the highest chance of getting a recurrence for, I think, any cancer would be the first 2 years. Technically, yes, we should be able to, technically they should be able to conceive a pregnancy even before that. If now, if I am to say following chemotherapy, usually if we are to consider that ovaries have recovered, usually they need to start ovulation naturally, and usually for us to check whether the ovulation is, to us to check the reserve of the ovum reserve, usually we have to wait for 3 cycles before AMH level is done. So technically, we don't have to wait for 3 years. If that happens early, naturally, especially in a young woman with a large ovarian reserve, they are bound to get back to the reproductive level early. However, I think in the context of a cancer, we have to consider that to make sure that she would not get a recurrence during a pregnancy, which should be a disaster. Especially like in breast cancer.
Anti-estrogens we are using tamoxifen like that, but the pregnancy also, when they are pregnant, they are not having estrogen in the system.
Yeah, in the pregnancy, the estrogen would go to very high levels.
But that after maintaining that progestin, because for safety, they say that having pregnancies is interrupting the estrogen high thing also, that those who are having multi-para, they are less likely.
Yes, but in the pregnancy, in the initial part, after the first trimester, yes, progesterone will kick back, but initially there will be estrogen.
That surge is a problem.
Surge will be there. So I think that 2-year interval is it's a very fair interval. Personally, I have not come across patient who has had conceived before that.
Now, how frequently would you use trachelectomy in a young patient who, if surgery, I mean, staging wise, if it permits?
So trachelectomy, I mean, in Sri Lanka, I mean, we really perform trachelectomies. One reason is most of women that are referred to us, they have advanced disease. And the other reason is Sri Lanka, the normal, usually the age of getting cervical cancer is several decades later than Western countries. So in Western countries, they say they would get in 30s. But what we have seen is in Sri Lanka, they would get in 50s. So by that time, most of our ladies would have completed their family. So it's extremely rare situations we would get a patient who has not completed the family and having a cervical cancer, which is less than 2 centimeters, no metastasis and operable. So personally, I have to say, I have only participated in only one trachelectomy during, so I have been doing gynae for about now 5 years. I have only seen one patient who is suitable for a trachelectomy, and that is during my foreign placement. So in Sri Lanka, I have not seen a trachelectomy being done.
One question from Professor Linda about this combining olaparib PARP inhibitor with temozolomide in some other small cell lung cancer and glioblastoma they are trying, but ovarian cancer, is it what is the mechanism? Can you enlighten on that, whether it may not be worthwhile combining in ovarian cancer?
Yes, I'm aware of that study where they combined the Beijing PARP inhibitor with temozolomide, and it did seem to have some activity in small cell lung cancer. We actually had that trial open at Peter Mac, and it was active, but it was actually very myelosuppressive. So I think it depends on the situation. And in ovarian cancer, because PARP inhibitors are generally quite active as a single agent, we don't generally need to use that kind of combination. But there's obviously lots of study ongoing about ways to make PARP inhibitors more effective, such as by combining them with checkpoint inhibitors. So there's been a big suite of first-line trials that have been ongoing, and we're waiting for those results. We know that using checkpoint inhibitors with chemotherapy in the first-line adjuvant treatment by themselves don't seem to help, but we're anxiously awaiting to hear if maybe PARP inhibitors plus checkpoint inhibitor therapy may be helpful, although the prospect of giving women, 4 different drugs as adjuvant therapy is a little bit scary.
I asked because here in our setting, you can reduce the dose of olaparib and combining with temozolomide to get a cost-effective management or something like that. Thank you.
There's a question to Prof. Linda from a virtual participant. Is there a place for PARP inhibitor maintenance for clear cell or mucinous histology as well?
No, we don't think so. That the trials mostly were restricted to patients with high-grade serous cancers or high-grade endometrioid, and that they didn't allow patients with mucinous or clear cell cancers. I guess the exception might be if one of those patients actually had germline testing and carried a BRCA mutation, then there would be a role.
I have questions for Mr. Naik. Mr. Naik, that was very interesting presentation, and I was fascinated by your use of ICG for sentinel lymph node assessment. Could you please tell us, when you are injecting ICG to infundibulous pelvic ligament, is there a special anatomical position where would you just inject it to the connective tissue, or would you try to locate lymphatics and inject into the lymphatics? Thank you.
Okay. Yeah, thank you very much for the question. No, we just inject into the tissues surrounding the artery and the vein. We know the lymphatics tend to follow the venous structures. So any injection around those tissues will eventually end up within the lymphatics. So there's no special technique. I would simply add to say that at the moment, this is really still investigational. I think various other people are using different agents or injecting in different areas to try and determine which is probably going to be the best technique. So I think our method is simply to inject, as I showed in the video, which is at the base of the IP in the surrounding tissues, in the hope that it will then traverse into the lymphatic vessels.
Thank you very much.
Just one more question to Mr. Naik. Are there patient-reported outcome results after the extensive surgery you described?
Yeah, good question. Okay. There is the soccer trial, which is led by actually the current president of the British Gynae Cancer Society, which is Professor Sundar. So that is a means of trying to collect the kind of data that you're suggesting, which is quality of life and patient-reported outcome measures. And what they've shown is that, because the general belief is that by performing ultra-radical surgery, it's going to have a detrimental effect on quality of life. But in fact, that's not been shown. I think the quality of life for these women with advanced disease is poor already prior to the surgery. And in fact, for many women, you can improve the quality of life by achieving a good surgical outcome. It improves the overall tumor burden and obviously relieves a lot of the symptoms, including bowel symptoms and problems as well. So I think what that soccer study has shown is that there is no greater or more adverse effect on quality of life by carrying out ultra-radical surgery compared to standard surgery. What seems to be most important is achieving complete size reduction, and if it's more extensive, that therefore means carrying out more radical surgery.
Thank you. Thank you so much.
There's another question from the virtual participant to Dr. Naik. What criteria would you factor in when considering pelvic excenteration for recurrent cervical cancers?
Okay. Well, the standard criteria is that the recurrence should be central, and one is able to achieve R0 excision. In other words, complete tumor removal with a margin of non-tumor involved tissue surrounding the tumor, which basically means it needs to be a central tumor. Having said that, there is work that's being done, pioneered by Michael Hockel, in relation to pelvic side wall disease or recurrences. The objective here should still be to achieve R0 excision, which clearly is going to be much more complicated when you have a pelvic side wall tumor. So the criteria for those tumors are that it should be infrailiac, less than 5 centimeters, and involving only the obturator muscle, so that by removing the internal iliac structures and the obturator muscle, one can still achieve R0 excision. And as I say, this procedure called the LEA, or the lateral extended endopelvic resection, was pioneered by Michael Hockel. But many surgeons are now performing this. I've carried out quite a few in the past. And as you say, the criteria is critical. It needs to be infrailiac, less than 5 centimeters, and clear of bone and nerve structures.
One more question. Have you experienced any reduction in the second cytoreductive surgery after starting this maintenance olaparib in United Kingdom?
Okay, yes, it's an interesting question because as Linda's presented, you know, the results, certainly in HRD patients with use of PARP inhibitors, is outstanding. And the 2 randomized controlled trials that I presented were in patients pre-PARP inhibitor era. So the landscape's changing constantly. So no matter the recommendation now is we should be considering surgery for patients with recurrent disease. That's all changed now with the introduction of PARP inhibitors. So really, I think clearly I have operated on patients who have been treated with PARP inhibitors, and what we're seeing is that for many of these women, the bulk of the tumor reduces, but there can sometimes be 1 or 2 foci of tumor that hasn't shrunk. So what we end up doing is working much, much more closely with our medical oncology colleagues. And as they are personalizing the chemotherapy, we're also personalizing the surgery. And we're targeting individual tumor deposits that have not shrunk with the use of PARP inhibitors or bevacizumab.
We can allow one last question from the audience.
In advanced ovarian cancer, what is the place for debulking surgery, then followed by chemotherapy? Whether we can go for a radical surgery followed by the chemo?
Yeah, well, I mean, my standard is still primary surgery followed by 6 cycles of chemotherapy. And that is partly because all of the debates relating to the studies for neoadjuvant chemotherapy can be interpreted in different ways. And I think there were certain criticisms of the studies, in particular the CORA study, where the site reduction rates were not as high as expected. So I think people were questioning whether a maximum attempt at site reduction was performed at the primary laparotomy. So for that reason, I think people were reluctant to change their practice. The recent Scorpion study, which is from the Italians, is from a center that is renowned for the quality of its surgery. And again, they got an equivalent result. So I think, you know, bit by bit, more and more people are beginning to consider neoadjuvant as the standard. But at the moment, if you have a young, fit, healthy woman with radiological evidence to suggest that you can achieve a good site reductive outcome with a primary laparotomy, then that would be our standard. Linda, what do you think? Well, how are things in Melbourne?
Yeah, exactly the same. But yeah, there has been this creep. I think now we're seeing probably about 60% of women starting with neoadjuvant. But when we have a good candidate for primary debulking, that's what we do.
Yeah.
Thank you very much for those excellent explanations and clarifications. Then let's wrap up the symposium on gynae-oncology. Dr. Rajita Vijay-Singha, thank you very much for joining us today to share your knowledge and experience with us. Please remain on stage to receive a small token of appreciation from SLCO. I would like to invite Dr. Jayakumaran, President-elect SLCO, to give away a token of appreciation to Dr. Rajita Vijay-Singha. Thank you, gentlemen. Dr. Mleshkin and Mr. Naik, we are much grateful to you taking your time today to join us virtually at SLCO annual academic sessions. Hopefully, with the improvement of global pandemic situation, we look forward to seeing you here in person next year for next year's sessions. With that, we are moving to the final item of today's proceedings, Plenary 6, Role of Neoadjuvant Chemotherapy in Breast Cancer, delivered by Prof. Jean Abraham. Professor Abraham is a professor of precision breast cancer medicine and honorary consultant in medical oncology at the University of Cambridge. She co-leads the Integrated Cancer Medicine team and the breast program in the Cancer Research UK Cambridge Centre. She is Deputy Team Lead for Cancer at Cambridge NIHR Biomedical Research Campus. She is Chief Investigator of 8 national and regional trials. She received a national CRUK PhD fellowship, received her PhD from University of Cambridge in year 2011. Her research aims to use multimodal data integration to develop predictive and prognostic tools to provide individualized treatment for breast cancer patients. Over to you, Prof. Abraham.
Hello, and thank you very much for inviting me to the academic sessions for the Sri Lankan College of Oncologists. I was born not very far from Sri Lanka in the state of Kerala in India, and it's a shame that I'm not there in person to meet you all. But my name is Jean Abraham, and I am the Professor of Precision Breast Cancer Medicine at the University of Cambridge. I'm going to talk to you about neoadjuvant chemotherapy and then use triple-negative breast cancer as an exemplar subtype for the platform of neoadjuvant chemotherapy. These are my conflicts of interest. So we'll start by asking the question, why do we use neoadjuvant chemotherapy? So we use neoadjuvant chemotherapy to control systemic micrometastases, reduce the tumor burden, and also to provide surgical or conservative breast surgery options for locally advanced breast cancer patients. As a bonus, it also allows us to detect tumor sensitivity to chemotherapeutic and targeted agents, and also allows us to see the potential risk of relapse, because pathological complete response presence or absence at surgery can indicate the survival potential for certain subtypes of breast cancer, such as triple-negative and HER2-positive breast cancer. The Early Breast Cancer Clinical Trialist Collaborative Group actually looked at whether neoadjuvant and adjuvant chemotherapy were comparable, and they found that there was no significant difference between neoadjuvant chemotherapy versus adjuvant chemotherapy in terms of distant recurrence or breast cancer mortality. The use of neoadjuvant chemotherapy was associated with an increased frequency of breast-conserving therapy, and it was also associated with an increased risk of local recurrence, and that was attributed to the increased use of breast-conserving surgery. The increased risk in local recurrence, however, was not associated with any significant increase in distant recurrence or breast cancer mortality. So neoadjuvant chemotherapy is perfectly acceptable, safe, and in fact, potentially more useful than adjuvant therapy in some settings, as long as we are careful to do careful tumor localization, detailed pathological assessment, and appropriate radiotherapy, all of which we should prevent local recurrence. So triple negative breast cancer is probably one of the best examples for neoadjuvant therapy as a platform. So early stage triple negative breast cancer is often treated with neoadjuvant chemotherapy. And in this setting, we are really looking at whether at the end of this chemotherapy, the surgery shows that there is no residual cancer, or if there is in fact residual cancer. And increasingly, we are using something called residual cancer burden scores to estimate this. And here you can see on this diagram that residual cancer burden 0 equates to what we call pathological complete response. Residual cancer burden 1, which is we could also call minimal residual disease, it equates to a similar kind of risk as pathological complete response, but perhaps not as good. And we'll see the Kaplan-Meier curves for that in a second. Residual cancer burden 2 and residual cancer burden 3 show that there is moderate and then extensive disease left at surgery. And these are reflected in the Kaplan-Meier curves. And this is the relapse-free survival Kaplan-Meier curve, where you can see that residual cancer burden 3, which is the red line, and residual cancer burden 2, which is the gray line, all show that over time have much more increased rates of relapse in comparison to those patients who have either RCB 0, which is pathological complete response, or RCB 1. So pathological complete response has now become an acceptable potential endpoint in clinical trials to accelerate the approval of certain drugs in high-risk breast cancer subtypes. And that was a statement made by the FDA a few years ago. So let's take a look at triple negative breast cancer in a bit more detail. So it's characterized by the absence of ER, PR, and HER2 expression. It's about 15% of all breast cancers. It expresses basal cytokeratin such as CK56 and CK14, and also we check for the expression of EGFR. About 10% of triple negative breast cancers also express androgen receptor. So again, we check for androgen receptor presence. It's a highly heterogeneous disease and has a variety of both histological and molecular features. Approximately 10 to 20% of triple negatives harbor a germline BRCA mutation, and about 70% of BRCA1 mutations and 16% of BRCA2 mutations are triple negative. Immune activation varies within these subtypes, and the current treatment for early stage triple negative is very much still a one-size-fits-all approach. And you can see here listed some of the mutations that are commonly associated with triple negative breast cancer. And probably one of the commonest is P53, which is seen in about 84% of people who have triple negative breast cancer. And the rates of these mutations do vary slightly from study to study, but this is a pretty good summary from Garrido Castro in Cancer Discovery in 2019 of the relevant mutations. The molecular subtyping of triple negative breast cancer has also changed over time. The first proper subtyping of triple negative breast cancer was really done by Lehman and Pietenpol in 2011, where they pulled out 6 specific subtypes. And you can see the main 6 here with the addition of the unstable on top of those 6. And these classifications have been optimized and changed both by Lehman and Pietenpol themselves, and also by other groups such as the Burstein and Yang groups. And all of them are really splitting up the triple negative molecular landscape into those that have a basal or immune phenotype versus those that have a more androgen and mesenchymal type phenotype. in the standard setting, what do you actually need to subclassify triple negative breast cancer? I mean, we know that most people in the standard setting do not have the facilities or perhaps the money to do the kind of molecular testing that has been shown there. And in addition, that kind of molecular testing takes time to actually generate and analyze. So what kinds of things can you do in real time in the clinical setting? So germline assessments for BRCA1, BRCA2, and now PALB2 as well should really become part of our assessment, particularly for younger age triple negatives. Histopathological subtypes should be looked at. Apocrine and metaplastic subtypes often can be treated differently to the more basal subtypes. And then IHC-based tests such as PD-L1, PD-1, CK56, EGFR, ELPR, and HER2. The more sophisticated testing can include tumor microenvironment testing, so TILs, tumor infiltrating lymphocyte testing, and other immune cell profiling. Genomic and transcriptomic information, which can contribute to the kind of subtyping that we looked at just before on the previous slides. So let's just take a very quick look at tumor infiltrating lymphocytes. So there is a strong independent association between TILs and survival outcomes in triple negative breast cancer patients. And of course, you can assess TILs upfront, prior and post neoadjuvant chemotherapy. A pooled analysis of 9 studies showed that with 2,148 patients, for each 10% increase in TILs, there was a 17% reduction in the risk of distant disease-free survival and also overall survival. There was improvement in survival across all nodal groups, and an increase in TILs was associated with pathological complete response post-neoadjuvant chemotherapy, and in particular with platinum agents. So immune therapy is very, very high profile at the moment and being used in multiple tumor types and in multiple subtypes of those same tumor types. In breast cancer, probably the area that it is most likely to be used in, at least in of itself and without adjuncts like radiotherapy, are the triple negative platform. So PD-L1 expression is detected currently using immunohistochemistry, and of course also you can detect it using expression data and molecular profiling. PD-L1 expression can be found on both tumor cells and on the immune cells. It's useful, but it's an imperfect predictor or biomarker of response to both anti-PD or anti-PD-L1 antibody therapy. PD-L1 is a protein that's recognized by the receptor PD-1 on the surface of the T cell, and PD-L1 positivity is based on an immune cell score of greater than 1%. And this refers to the area occupied by PD-L1 positive immune cells, which can be of a variety of different types, in comparison to the percentage across the whole tumor area. Approval for PD-L1 scoring is required in the metastatic setting for drugs like atezolizumab, and of course the Keynote study, which we'll talk about shortly, also used PD-L1 scoring as part of its study assessments. So PD-L1 positivity is, as I said, a criteria for metastatic disease in the routine setting at the moment. The Keynote 522 study, which was presented at San Antonio in 2019 initially, is a study that looked at 1,174 patients randomized in a 2-to-1 fashion for pembrolizumab plus standard chemotherapy versus standard chemotherapy plus placebo. This was in the neoadjuvant setting. And then what was more interesting and perhaps a bit more controversial was that the patients were then given 27 weeks of pembrolizumab or placebo in the adjuvant setting. And the pathological complete response rate in the initial analysis was 63% in patients who received pembrolizumab, compared with 56% for those who got chemotherapy alone. And the FDA approved pembrolizumab in early triple-negative breast cancer in July 2021. Now, this is still under review in many European countries and quite possibly Asian and South American countries as well. And partly this is because of the adjuvant arm. It is really unclear at the moment whether 27 weeks of adjuvant immune therapy with all the potential side effects that brings is required in order to achieve the longer term overall survival results that are hoped for. But nonetheless, it's clear that immunotherapy is coming, in particular to triple-negative breast cancer. The other controversial area is whether you should give platinum or not give platinum in the neoadjuvant setting. And opinions really differ. There is very strong evidence from 3 neoadjuvant studies that very much supports the use of platinum in triple-negative breast cancer. And in the UK, 2 different types of regimens are used, which are platinum containing. The platinum agent is usually carboplatin, and it can be used with either weekly paclitaxel or 3 weekly docetaxel. The non-platinum containing regimens that are used are either FECT or ECT, and obviously the scheduling can be other way around, depending on what the oncologist feels is appropriate. My personal opinion is that platinum should be used in all patients, particularly if they have any high-risk features at all. And that's certainly what we do in Cambridge. So genomic investigations that are coming into clinical practice in the near future will need to be things like rapid germline testing, because undoubtedly the results of the Olympia study, which we'll talk about shortly, definitely show that knowing your BRCA status up front is going to become increasingly important. Whole genome sequencing of the germline and somatic, and also the RNA data is coming in the UK via our genomic laboratory hubs, but those genomic laboratory hubs will not be using RNA sequencing, just DNA sequencing. To be honest, I think that you need to do both RNA and DNA sequencing to get full value, and also to do the types of subtyping that we would like to do. HRD testing of various kinds, by mutational signature testing, are also becoming more and more popular. Tumor molecular burden testing, again as an indicator for immune therapy, is becoming more commonplace, and immune profiling itself. Another interesting and soon sort of near future component is also the use of circulating tumor DNA as a component to monitor and track patients in terms of both response to treatment and also relapse. So I'm going to change tack now and tell you a little bit about some of the work that we're doing in Cambridge, which is really bringing together the genomics and the clinical trials aspect in the neoadjuvant platform, and in triple negative as an exemplar for that. So PARTNER is a triple negative breast cancer neoadjuvant trial, which compares standard of care chemotherapy, which I will show you is carboplatin containing regimens versus carboplatin containing regimens and olaparib. And the regimen schema is shown here. The eligibility or inclusion criteria is for germline BRCA mutated patients or triple negative patients. We have slightly enriched the study for the basal phenotype by excluding patients who are androgen receptor positive and then negative for the basal immunohistochemistry markers. So originally the study had was a 3-stage design with a safety component when we started, then an arm selection component. That was the stage 2, where we were deciding between giving the olaparib starting before chemotherapy or after chemotherapy. We have since been told by our independent data monitoring committee to continue only with the olaparib starting after chemotherapy component. So now this trial is a 2-arm study, randomizing between standard chemotherapy and standard chemotherapy plus 12 days of olaparib at 150 milligrams BD, starting on day 2 after the chemotherapy has completed. And the olaparib is given, from day 3 to day 14. And so we are in the final stages of getting the number of patients we need to look at the triple negative cohort, and then we will independently look at the BRCA cohort down the line. As part of this study, what we are also doing is looking at the translational component. And what you can see here are the timelines for the different cycles, and also along the sides you can see all the different types of sampling that is being done, and the types of novel and standard radiotherapy assessments that are being done. And I will focus in a second on this study, the Personalised Breast Cancer Programme, which is our sequencing study. So I'd like to cover, first of all, to make sure that we're all on the same page, is what whole genome sequencing actually is. So whole genome sequencing, as I'm sure you all know, is looking really at the component parts of DNA and reading those component parts and looking at the order of the nucleotides within that DNA molecule. I suppose you can compare it somewhat to what it would be like to read a book. So sequencing uses phrases like read and depth. And so when you are sequencing a tumor genome, you will read the genome several times. So if I compare this to reading a book, if you read a book just once, you will understand something about the story and what the book is about, but you'll probably forget it fairly quickly and you won't remember a huge amount about it. Similarly, if you just read a genome once, you would get some information, but not a huge amount. You would also not really be able to tell as much as you'd like to what the errors were compared to what the real data was. So when we read the genome, we read it several times. And in comparison to what we used to do, which was panel testing, rather than just looking, for example, at the genes of interest, which would be equivalent to looking at just the chapter headings of a book, we read every page and every line on every page. And the depth refers to how much detail that you read the genome in. So if you read a book very quickly, you'll get some information, but again, not the detail. Similarly, if you use a low depth sequencing, you'll get some information, but not as much as you could do if you did a really deep sequencing. So those are some of the terms that are used in sequencing and what sequencing is. Now, of course, cancer has got 2 genomes, and one is the somatic or tumor genome, which really tells us about what's changed since the patient got the cancer. And then we have the germline genome, which is what you inherited from your parents. In both the RNA and the DNA, we are looking at variations, so too much or too little of specific genes or regions, which can be called gains or losses. Sequencing generates a great deal of data, and there is a real need to understand what's the important signal and what's the noise. And that's really where much of the work is done and where we need really top-end bioinformaticians to understand and generate new pipelines that can help us to do this better and better. So this is the Personalised Breast Cancer Programme, which allows patients of any stage of breast cancer and any subtype of breast cancer, in fact, to consent. We're running this in Cambridge and we're now opening this nationally across different sites in the UK. Patients consent and then give us a tumour and blood sample. That tumour and blood sample is then sent to our industry partner, which is Illumina. They then do our sequencing for us, and then we get a readout of what we call the tier 1 genes, which are the key important actionable genes. That's then reviewed by our oncogenomics review board. If there's anything that we think is interesting, we will validate it or double test it. And then those results are sent to the clinician and the patient. And the types of changes we look at might be mutational signatures, mutational burdens, molecular subtypes, drug toxicity risk, hereditary risk, and the different types of mutations that you can see. In parallel, those may end up with changes in your treatment, in the prophylactic surgery that you get, family screening, clinical genetics, etc., etc. So to really put this into perspective, we should really look at how it impacts on 3 very similar looking patients who are all participating in both the personalised breast cancer programme and also partner. So here you have 3 patients, all roughly the same age, and these are real patients, albeit we're not using their name or any identifiers. And they are aged 67, 66, and 69. They all have early stage triple negative breast cancer, and they all are of very similar stages. But when we get the data from the personalised breast cancer programme and look at the responses from partner, what we see is in the first lady that she's actually a Lynch syndrome carrier, and she actually had a PMS2 gene deletion, which meant that she has an increased hereditary risk of colorectal cancer and an endometrial cancer. And in fact, her whole family had opted to be screened as well. And so what we also know about patients like this is that she had a high level of tumour mutational burden, so lots and lots of mutations within her tumour, which means that if she relapses, the best treatment for her is likely to be immunotherapy. Fortunately for her, 4.5 years ago when she finished her treatment, she had a very good response and she remains to this day very well. The next lady is a 66-year-old lady who was actually found to have a gene, a BRCA1 gene, which gives her an increased risk of breast and ovarian cancer. And again, her family needed to be screened. She actually got the control arm, and if she relapsed, she would need to be treated with a drug like olaparib, which is a PARP inhibitor. And in fact, she did not have such a good response to the control arm. The final lady is a lady who was 69 years old and in fact had no hereditary genes, but in fact was seen to have changes in her germline data, which showed that she'd be sensitive to certain types of chemotherapy. As a result, we know that should she relapse, we would avoid certain types of chemotherapy in that setting. But again, fortunately, she's had a very good response and to this day remains fit and well. So you can see that superficially these women look very, very similar in clinic. We've looked here really only at the germline changes, but similarly we could look at the somatic changes and see that some different patients may have mutations in different pathways, which may indicate that at relapse that they should have different targeted agent therapy. So this has really changed the way that we treat our triple negative breast cancer patients. And this information comes in real time within 9 weeks, usually, of their having started their neoadjuvant chemotherapy. So one of the things that I find as an oncologist is that much of my research is very driven by what my patients say to me. And this was a particularly moving comment by a patient who was a second opinion referral from another hospital. She said, I know I have, she had undergone non-platinum containing neoadjuvant chemotherapy at another hospital, and she'd had quite a lot of residual disease. And she was a very bright woman who had looked into this disease in a great deal of detail. And when she came to see me, she said, I know I have a really bad outlook. I feel like there's nothing I can do about this. There just doesn't seem to be any treatments available after you finish chemo, surgery, and radiotherapy. Every new drug seems to take forever to be available for me, and I'm worried it will come too late for me. And that comment really stuck with me and my team. And we decided that we would change the partner study so that we put in a sub-study for poor response patients within partner. Now, obviously, that particular woman wouldn't have been eligible for this, but for patients coming down the line who are in partner, were they not by the 6th cycle to have got, radiologically at least, as good a response as we would hope for, then we will do a biopsy to prove that they do indeed have disease remaining. And then we would allocate them into a 8-week treatment option. And at the moment, there's only one arm open, but we are opening further treatment options into this setting. And at the moment, these patients would get an ATR inhibitor, AZD6738, plus an immune therapy, durvalumab. And they'll get 8 weeks of that before they go to surgery. And the idea is to see if there is any change in the amount of tumour that's left, but also to actually look and see if there are any biomarkers that indicate that there might be some kind of response from having had this treatment. And this study will continue beyond the triple negative component of partner. So what happens when a patient who has triple negative chemotherapy has a lot of residual disease left? So we're now really thinking about the post-neoadjuvant setting and what happens when you know, for example, in the HER2 and triple negative setting, that you have a patient who is likely to do badly and they have residual disease left. So the first study that came out in this setting in the triple negative arena was CREATE-X. And CREATE-X was a 910 patient study done by a Japanese-Korean collaborative, and they saw that the rate of disease-free survival in the triple negative cohort within their study group had a better overall survival and disease-free survival response if they received capecitabine. Now, this was greeted with great interest, but not taken up as standard of care routinely by most centres. And actually, since then, a couple of other studies have done a similar study looking at capecitabine, and one of them is the Ciboma study from the Spanish group, which in contrast has a Caucasian population, and they found that there was actually no statistically significant increase in disease-free survival with the addition of capecitabine to chemotherapy in the post-neoadjuvant setting. They also had a pre-planned subset analysis looking at basal versus non-basal phenotypes. And it seemed that where there was benefit, it actually came from patients who were of the non-basal phenotype. So this is still a very controversial area, and it's unclear exactly whether we should be giving all our patients capecitabine who have residual disease. And in fact, in the UK, what we find is it's a very much consultant by consultant decision. And from my own perspective, I have a very detailed discussion with the patient and have a very good look at their molecular and histopathological data before I actually advise whether they have capecitabine or not. And it would be interesting to know what your practice is. One of the other areas that are going to become very important in triple negative breast cancer in the neoadjuvant setting undoubtedly comes in the post-neoadjuvant setting, in fact, for BRCA carriers, where the Olympia study, which randomized both adjuvant and residual disease post-neoadjuvant BRCA carriers to olaparib maintenance dose of 300 milligrams BD versus placebo, was shown to have a clear benefit in terms of distant disease-free survival in the olaparib receiving group. And this has really started to raise eyebrows in terms of what we should be doing with BRCA carriers who do have residual disease post-neoadjuvant therapy. So these are some of the interesting areas in the triple negative arena. We don't really have time to discuss the HER2 neoadjuvant setting, but again, I would say to you that some of these areas are areas to focus on and keep an eye on in terms of upcoming trials and studies. So HER2-directed therapies, obviously trastuzumab and pertuzumab in combination with standard chemotherapy, either taxanes and taxanes or platinum agents, have now become pretty much standard of care. But conceptually, things like the HER2 low tumors are going to become something that we hear more and more about. And again, the adjuvant component of post-neoadjuvant care is important. We know that the Persephone trial asked questions about whether 12 months of Herceptin was really needed. Or whether 6 months would do, and there was an equivalence there for some of the patients. Similarly, if you are high risk, should you be giving trastuzumab and pertuzumab for a fixed period of time? Again, in the residual disease setting, a bit like with capecitabine, TDM1 is now approved, and there will be other alternatives such as immune therapy and CDK4/6 inhibitors that will come out in the ER positive, HER2 positive, I should say, setting. So there are lots of really interesting areas in the neoadjuvant and post-neoadjuvant setting, both in triple negative and HER2. And we haven't really mentioned the ER positive arena because it's a little bit more complicated and it's harder to know exactly which patients should be having neoadjuvant chemotherapy. So in summary, the neoadjuvant treatment platform is a really clinically important platform, which both from a surgical and clinical perspective is important to patients. It's translationally extremely rich and may help to identify high-risk patients that require additional adjuvant therapies. And we are likely to see an increase in the numbers of neoadjuvant trials in the future. So thank you very much for listening. And of course, thank you to the programme members, our patient advisory group, collaborators and funders in Cambridge and around the world who have collaborated on many of the studies that I've shown. And I look forward to talking with you on the 14th and answer any questions that you have. Thanks very much.
Thank you, Professor Abraham, for the interesting lecture. I think we can accommodate a couple of questions from the audience.
Thank you very much for the very interesting lecture. And you mentioned about the androgen receptors in triple negative breast cancer, and just we want to know some more about that because it's 10%. We have androgen receptor inhibitors or blockers. So what's the place in the future, the androgen receptor?
Yeah, that's a great question. I think those trials are still in evolution. Trials using enzalutamide and also bicalutamide have been looked at, and I think the real answer is we don't know yet, but there will be trials coming up in the next, I would say probably 2 to 3 years that will give us an idea of whether there is a particular type of androgen receptor positive triple negative breast cancer patient in whom we could start to do treatment, for example, with bicalutamide, enzalutamide and similar drugs. So I think molecularly those subtypes definitely appear to behave more like estrogen receptor positive breast cancer patients. So it's very difficult to know exactly how that rolls out into the long-term future until those trials are completed. But I think that they probably do need to have a different treatment to the more platinum-based treatments that we're currently giving in the basal phenotypes.
Thanks, Jean. In the neoadjuvant setting for patients with ER/PR negative HER2 positive tumor, do you start with carbo, dosi, Herceptin straight away, or do you give adriamycin cyclophosphamide followed by dosi, carbo, and Herceptin? What is your practice?
So normally we give docetaxel with platinum as the first section of the treatment, and then go to the anthracyclines. That, and obviously then you can give the HER2 directed therapy alongside that regimen.
There's another question on our virtual platform. Are there any other active agents other than carboplatin for triple negative breast cancers?
I think from a chemotherapy perspective, the standard regimens that people use are carboplatin plus taxane followed by an anthracycline, or omitting the platinum and then just those sort of TFEC or TEC type regimens. In terms of other agents that are up and coming, there are a number. I mean, obviously, we've seen the Keynote study with immunotherapy coming in potentially. And the question there is really which patients should get immunotherapy that are triple negative or, in fact, have breast cancer in general. The other areas that are really interesting are the ADCs, so the drug antibody conjugate space is really coming to the front in the metastatic arena, and we'll see it soon coming into the early disease setting. The other interesting area is whether you can use radiotherapy plus drug to actually, if you like, activate immune cold tumors. So that there are a number of different agents and different strategies coming in both the neoadjuvant and the post-neoadjuvant setting in triple negative.
One more. How do you tackle the metaplastic carcinoma of the breast that harbors a triple negative? It is rare, but
yeah, I mean, it's a difficult one because at the moment we still treat them as if they are just a standard triple negative, but it's clear that they don't always respond the same way as your basal phenotypes. So at the moment we don't really have a solution for that. We are looking at various strategies for that, but currently they are still treated with chemotherapy. We may not necessarily give them platinum agents. We may just give a standard taxane anthracycline regimen.
Thank you.
What is the place for cisplatin gemcitabine in triple negative breast cancers?
Sorry, could you say that question again?
Cisplatin gemcitabine in triple negative breast cancers.
So, I mean, we don't tend to use gemcitabine in our triple negatives, I guess largely because we have data from quite a long time ago now from the Neo-Tango study where the addition of gemcitabine didn't actually seem to add anything to the neoadjuvant therapy outcomes. And the real value was in actually giving the taxane in that study, the real advantage to the patient was by giving the taxane as the first set of drugs as opposed to giving the anthracycline first. So I think the role of gemcitabine in the neoadjuvant setting is questionable at the moment.
Thank you, Prof. Abraham, and I would like to thank you for taking part in our session, and I hope you'll be able to participate in person in the next year's session. And with that, it brings down the curtain for the annual academic sessions 2021. And we have had a very interactive pre-congress workshop and two-day interacting lectures with the participation of local and international speakers. And I think you all would agree it was a huge success to organize an event of this caliber in the middle of a pandemic. And I would like to remind that all these lectures will be available in our virtual platform for the next 2 weeks. And I would like to invite all the trainees and medical officers to take part in the quiz and also in the teaching capsule to make use of the teaching capsule. And I would like to invite Dr. Sachin Rasnayaka, Secretary of Sri Lanka College of Oncologists, to play a huge role in making this event a success, to deliver the concluding remarks.
Thank you, Sachinda and Shashi. It's a great pleasure to all of us to see this success. And we all have a few minutes before lunch, and those who are with us virtually, we need to thank all of you. I know we couldn't thank in person during our inauguration. However, this is the time that we need to see how powerful when we are together. Where there is unity, there is always victory. Successful people are not gifted. They just work hard, then succeed on purpose. All the speakers and judges worked very hard, many days. Their hard work made this event a success. You proved it. So this big salutation for all of you, all the speakers who joined with us virtually, and the national and international speakers, this big thank is to all of you. And thank you for the job well done. Hard work is the best key to unlock doors of opportunity and success. This time, our door was unlocked by this great person. Now I call upon our president, Dr. A.J. Hilmi, to the stage to reveal certain people who worked hard behind the screen. Welcome, sir, to the stage. And meantime, I invite all the council members who are physically present here to the stage, because it's very useful. Without your hard work, without your support, we won't be successful today. Please come to the stage. This invitation to all the council members who are present with us. Please come forward. That will automatically give us the opportunity to have a group photo as well. Please. Appreciation is a wonderful thing. It makes what is excellent in others belong to us as well. We never know the worth of water till the well is dry. So when I accept this post as a secretary, Sri Lanka College of Oncologists, I didn't know how hard the work is. So who worked as secretaries, presidents in the past, gave me a big courage. So out of all of them, these are few members who gave me big courage, always with me and guidance me to go through this hard path. Dr. Sanjeeva Gunasekara, Dr. Nurad Joseph, Dr. Krishanti Rajasurya, thank you. Dr. Our treasurer, sir, where? Come. Our treasurer, Dr. Vasanta Ratnayaka, Dr. Nadraja Jayakumaran, our president-elect. You have to work very hard behind the scene. to make a message clear enough for a lot of people to understand. So, Dr. Sahan Priya Udara, please, Sahan, please come to the stage. Without your big support, I won't be able to do this hard work. So, Dr. Pradeep Siriwadana, Dr. Yasiru Malinda. Yasiru Malinda, please come forward to the stage. Dr. Yoganathan, please come to the stage. You're one of the council members, please. Dr. Siddharth Vijayasekara. Please stay in the stage, Malinda. Everyone, please stay in the stage. Dr. Janaka Tushan, Dr. Ravindi Miriam. Ravindi. Dr. Nirmali Kumara Singharachi. You have been a valuable member of our team, and we have noticed all the hard work you have put in. Keep it up. So there are few names that without mentioning their name, I won't be successful in this closing remarks. So again, you are the pillars of success of this session. Dr. Sanjeeva Gunasekara, Krishanti Rajasurya, Nuraj Joseph, Buddhini Karunaratna, Dilip Mahaliyana, Naduni Imbulgoda, Vimuktini Piris, Buddhika Somavardhana, Yasinta Ratnayaka, Laksha Nabenayaka, Sachinta Vijay Sirivardhana, Sashi Bamunuarachi. Please come to the stage. Please. And all of you, without your presence, we won't be successful today. So this time we found virtually and physically, we had great support with your presence. So everyone in the stage, everyone in the audience, please come to the stage and join with us for this group photograph. Please come. Please come forward. Audience today, Minoli, please bring your team and come to the stage. Everyone, please come to the stage. This is the only opportunity that it proves the unity makes the success. Oh, yeah. So I'm so happy that your dedication has paid off in a big way. Keep up the work. Our sponsors today, without your support, we won't be able to successful. So platinum sponsors, all platinum sponsors, please come and join with us. Beacon, Hemas Kansas, Roach, Bowers, Tabrain, Bago, Seoul, George Stewart, Sioka, Amart, Arcity Surgical. Please join with us for this group photo. Be thankful for what you have. You'll end up having more. If you could concentrate on what you have done, you will, what you don't have, you will never ever have enough. Nice. So all allied sponsors, corporate sponsors, so this big thank for all of you. Without your support, we won't be able to successful. So you all can join with us. Oh, Ali, you all can. Everything is hard before it gets easy. So this last but not least, the big thank goes to Tarang, our coordinators, Taranga Alutweva, Deepika Rajasurya, Oshadi De Silva. Please come forward to the stage. And there's a small gift for them. Yes. Taranga, Deepika and Oshadi, please come forward. Sir, Naduni, the gift. So your hard work, AV Productions and Galadari Hotel members. So this big thank for all of you. And last, our photographers today. Make a post, make group with the post. You all can broadcast the group. Taranga, Deepika and Oshadi, please come to the stage.
Hello. We will be very soon. We will see you for the ASCO Sri Lanka, ASCO Asia Sri Lanka, and then 2022 sessions. Thank you.